experiencing this program. Very appreciative you've all chosen to spend what's supposed to be a truly beautiful day, a long-awaited beautiful spring day for us here with us in this beautiful but not very exposed to the outside auditorium. For those that I haven't met, I'll introduce myself very briefly. My name is Evan Hall. I am a melanoma medical oncologist here at Fred Hutch. And I have been involved in this event for at least 5 or 6 years. Shortly after I started on faculty here, I started co-running the event with Dr. Bird and then have been running it the last couple years now on my own. I just wanted to say a few things about the event and orient us all, and then we'll go through the program and then we'll get started. So this event has been going on for somewhere approximately in the 25-year range. We have to actually figure out when the first event was because it's so long ago we're having a hard time remembering the exact year. That's long before I was involved in melanoma care, but Dr. Bird identified a need and started this event. A need to have a place where people could gather to learn, share experiences, and participate in something that's both educational and holistic and about healing and wellness. And so that was really the foundation of this event. So a huge thank you to Dr. Bird, who is still around. I still am fortunate to get to see him regularly. And I'm very honored that he's, continued this event and let me become involved. We have 272 attendees this year, which is basically the same number we had last year, which was a record. So I consider this to be tremendous success yet again. Thank you all to registering and for your interest. Big thanks to the speakers in advance, to the ongoing support from the MRF, without whom this event would be very difficult to host. And they've been wonderful partners over the years. And then to Ritu and her team for organizing it and taking care of all the logistics. So this is what we're in for today. A very exciting, I'm very excited about this agenda. So the theme is kind of going from the small to the larger in terms of the first half, where we'll be looking at about mainly scientific aspects of melanoma and advances in treatment, starting from the very foundational aspect of how melanomas become melanomas, through changes in evolution of surgical management for primary melanoma tumors, to understanding more about what the current practices are for patients who require medicine for their melanoma, and also what's on the horizon that might be coming next that could be of excitement and impact for our patients. After lunch, we will have a presentation from MRF, and then a couple topics about lifestyle impacts on cancer and things that patients can learn more about, and everyone can learn more about. Honestly, I'm looking forward to learning about sleep and exercise. But how these elements are very important in wellness and promoting health. And then we'll end with a slight variation on the patient stories, which I hope will be well received, and then we'll wrap things up shortly before 3 p.m. There will be a break in the morning and a lunch break as seen here. The last thing I'll say, so before we get to this, there are 2 tables outside from the main registration table that I would encourage you to stop at during a break or over lunch if you haven't already. There's a wonderful table organized by the MRF that has a lot of information about their mission and their organization and how to get involved. And then there is a table related to Fred Hutch melanoma research and outreach as well. I just highlight a few of the flyers that we have for that. Upcoming is our Fred Hutch Obliteride Cancer fundraiser. There is a team for melanoma. There is also a team for ocular melanoma. I saw a few folks register who are in that subgroup. So there are relevant flyers if you're interested in participating for that, if you want to learn more. And then there's an informational handout about our skin cancer biorepository research program, which anyone who's been diagnosed with melanoma could decide to join. And if you're interested in more on that, look for this flyer out there on the table. So, just a few housekeeping items. This will be recorded, and anyone who's registered will receive links to the recordings of this event. So it's not your only chance to see the material. You're welcome to take notes, but you'll have the ability to access these talks later on. For those that are attending virtually, you can use the chat function to ask questions. I will run that during the Q&A and try to get to as many of those virtual questions as possible. For those in person, we'll have time for Q&A at the end of each talk, and we'll circulate microphones so that everyone can hear the questions, including the online audience. Lastly, and very importantly, please fill out the feedback form for the event. We plan each event based heavily on the feedback from the prior year. And many of our topics this year were suggested by the feedback forms from last year and years past. So it really helps us as we think about, say in the agenda, the purpose of this is to be meaningful to you and answer your questions and address areas that you want to learn more about. So I really encourage you to fill out the feedback form. It really helps us understand how we're doing and how we can improve. So with that, I will get started and introduce our first speaker. So for our first keynote presentation, it's my pleasure to welcome Dr. Hunter Shain, who is an associate professor in the Department of Dermatology at University of California, San Francisco. He is a laboratory scientist whose goal is to understand the biology of skin cancers and how they evolve from normal skin cells into skin cancer. His laboratory uses a variety of technologies to help understand this. He is a worldwide leader in cancer evolution among skin cancers. He serves as the lead investigator of the NIH Human Tumor Atlas Network. And really through insights generated by his laboratory, we're hoping to improve early detection, diagnosis, treatment, and outcomes for those who've been diagnosed with skin cancer. He has many awards and accolades, but I just will highlight a few. There was in the news recently a very high-profile study that got a lot of press attention describing what's happening molecularly when people use tanning beds. So he's published on that. He's received many awards, including the Young Investigator Award from the Society for Melanoma Research and the Next Gen Star Award from the AACR. So without further ado, it's really a pleasure to welcome Dr. Shain for our first keynote speech. Thank you.
See the laser pointer? Okay, great. Thank you, Evan, and the organizers for the invitation to speak today. It's really a thrill to kick off this event where I will walk you through the journey from a melanocyte to melanoma. These are my industry disclosures, and allow me to begin by overviewing the taxonomy of melanocytic neoplasia. Melanocytic neoplasms can be stratified into two dimensions. First, based on their clinical subtype, and second, based on their disease stage or how far they have progressed. The World Health Organization currently recognizes 9 clinically distinct subtypes of melanoma that are each thought to evolve via a different progression trajectory. Now, if you're looking at this slide and you're thinking, I don't recognize any of these names, I was just told that I have melanoma. You probably have one of the two most common forms of cutaneous melanoma, which are known as the low and the high cumulative sun damage subtypes of melanoma. And I'll talk about them in more detail starting in the next slide. But there's also this tail of rare subtypes of melanoma. And if you have one of these, you probably do know that you have one of these subtypes. And just out of curiosity, are there any patients here or caregivers for patients that have one of these rare subtypes that are listed here? Yeah, oh, there's a few of you. Okay. So these are really a completely different beast. I'm going to talk about them towards the end. But we'll start out by discussing the two most common forms of cutaneous melanoma, the low and the high cumulative sun damage subtypes of melanoma. So the high CSD melanomas, these arise on body sites that are chronically sun exposed, so typically your head and neck region. They increase in incidence with age, have extraordinarily high mutation burdens, and a distinct set of driver mutations. And by that, I mean the mutations that are ultimately responsible for the uncontrolled proliferation of these cells that I'll discuss in more detail in the next slide. Now, by contrast, the low cumulative sun damage subtype of melanoma, these arise on body sites that are more intermittently sun exposed, such as your back, your chest, your trunk, and various extremities. And they have this peculiar age of incidence. They're actually somewhat more common in younger people. And so if all you told me is that I got melanoma in my 30s or 40s. Without knowing anything else, I would assume you probably have the low cumulative sun-damaged subtype of melanoma. Now, as for their mutation burdens, they are high if you compare it to, let's say, an unrelated solid cancer, such as breast or prostate cancer, but they're somewhat lower than the high CSD subtype of melanoma. And they, too, have a distinct set of underlying driver mutations. Now, if you have read some of your pathology reports and you saw some of these other names over here, I do apologize that we have changed the names of these two types of melanoma many, many times over the years. But today, in order to avoid confusion, the World Health Organization has recommended the adoption of these terms, the low and the high cumulative sun-damaged subtypes of melanoma. So as promised, this is my best attempt to collate all the genes with bona fide pathogenic mutations in the various subtypes of melanocytic neoplasia. And there are quite a few, but to simplify it, I've tried to highlight in the darker shades of red or blue those genes that are the nodes, the most commonly mutated in a given subtype of melanoma. And I contemplated removing the slide given that this is a patient presentation, but I think the information here is critical, especially if any of you have considered in your differential treatments targeted therapies. So the low cumulative sun-damaged subtype of melanoma, a cardinal feature of this is the presence of what's called a BRAF V600E mutation. And this results in activation of the MAP kinase signaling cascade. And there are quite a few drugs out there that are potent inhibitors of BRAF V600E. And they work, if you define work as meaning they will at least initially shrink tumors. But regrettably, for most patients, they do eventually show a relapse. And in the research community, we are working, I promise, day and night to play this game of whack-a-mole to identify additional targets to prevent that relapse. Now, fortunately, cancers do not form after a solitary oncogenic mutation. Our cells have evolved defense mechanisms, so it typically takes 4 to 5 different hits to result in the formation of a malignant tumor. And so for the low CSD subtype of melanoma, those additional hits most often affect PTEN, a gene called TERT, also known as telomerase, CDKN2A, P53, and ARID2. Now, the good news here is that this gives us additional theoretical targets, but the bad news is that the pharmaceutical industry has not been as good at developing inhibitors of some of these genes, and each one of these has their own story to tell. One common thread, you'll see that many of these are blue, and what that means is that's a tumor suppressor gene. And so from the cancer cell's perspective, it wants to turn that off. It's kind of like cutting the brakes on a car. And the pharmaceutical industry is quite good at inhibiting oncoproteins. They are not as good at fixing broken tumor suppressor genes. And so these have proven difficult to drug. Now, there are some other red genes on this slide, including probably the most prominent TERT, which is mutated in approximately 80% of melanomas. But for this one, we just haven't nailed that therapeutic window where we're able to inhibit telomerase at a level that will kill cancer cells without having unacceptable side effects. Now, the high CSD melanoma, they share many of the same complementary mutations in these other pathways. But a cardinal feature of these melanomas is activation of the MAP kinase signaling cascade through some other mutation aside from BRAF V600E. And the most common would probably be gain-of-function NRAS mutations. Now, interestingly, I'm steeped in the scientific world, and about 10 years ago, it was declared that RAS is an undruggable protein. But I'm thrilled to say that this is no longer true. Some of you have probably heard these stories from a company called Revolution Medicine in pancreatic cancer. They've developed this new drug, daraxonrasib, I hope I'm pronouncing that correctly, that is a RAS inhibitor, and it is doubling the life expectancy of patients with pancreatic cancer. And so we're keen to try out this drug in the setting of NRAS mutant melanoma. Now, if you force me to predict how this will work out, I think it probably will be similar to the experience with BRAF V600E. And so certainly for the time being, I think immunotherapies are the route to go, but it is potentially one additional new tool in our armamentarium against melanoma. So now I want to pivot and discuss the other dimension of the taxonomy of melanocytic neoplasia, and that is their evolution. And to better understand the evolution of melanomas from their precursor lesions, we assembled cohorts of informative neoplasms where we could identify a melanoma at that moment in which it was growing out of a pre-existing but still intact precursor neoplasm, such as in the example shown here. And what we did in the laboratory is we would microdissect and sequence the surrounding normal skin, the precursor lesion, and the fully evolved melanoma. And this allowed us to infer the order in which molecular changes occurred to cause this normal melanocyte to form a benign neoplasm and then eventually a malignant one. So we found quite a few different trajectories to melanoma, but I'm gonna just provide a high-level overview of the most common paths. And by far the most common path is for a low cumulative sun damage subtype of melanoma to evolve from a common nevus. So in this progression trajectory, a melanocyte will first acquire a BRAF V600E mutation, and this results in the formation of a nevus, also known as a common mole. Now, if a cell within this mole gets additional driver mutations impacting those other barriers to tumorigenesis that I showed you a couple of slides ago, that results in the transformation, in this case, of this mole into a low cumulative sun damage subtype of melanoma. Now, the second most common progression trajectory was for a high cumulative sun damage subtype of melanoma to evolve from a so-called intermediate lesion. These are typically dysplastic nevi. The pathology community has wrestled with what to call these. And consistent with these lesions being clinically and histopathologically intermediate, they were also genetically intermediate. And by that, I mean that they have more than one driver mutation, but fewer than the 4 to 5 driver mutations required to sustain a fully evolved melanoma. Now, the most common combination was for them to have some mutation in the MAP kinase signaling cascade other than BRAF V600E, and you will remember that this is a cardinal feature of the high CSD subtype of melanoma. They were always combined with at least one other oncogenic alteration, and by far the most common combination was a TERT promoter mutation. Now, if a cell in one of these intermediate lesions gets yet even more driver mutations, a third, a fourth, a fifth hit, that results in this case into the transformation of this, let's say, dysplastic nevus into a high cumulative sun damage subtype of melanoma. And so we felt like these studies were informative, but there was still a major gap in knowledge, and that is, where did the melanomas that appear de novo come from? And this is not a purely academic question. When you talk to dermatologists, they will swear that in many cases, their patients' melanomas are popping up seemingly out of nowhere, like a mushroom in a field, with no previous history of a nevus or any kind of a precursor lesion anywhere to be found in the vicinity. And out of curiosity, in the audience, did anyone have a melanoma just pop up out of nowhere with no history of a nevus? Or, yeah, I see a few hands. So we wanted to understand the origins and the etiologies of these melanomas, and we realized that in order to do that, we had to turn the clock back even further to measure the mutations in melanocytes from physiologically normal human skin. And so I'll pose a thought experiment to the audience, and that's how might you do that? And your knee-jerk reaction is probably, why don't we just sequence normal skin? But the problem with this approach is that it gives you an average signal from the complex mixture of cells that are there. Now, as it turns out, the most abundant cell type in your skin is a keratinocyte. And keratinocytes can give rise to their own scary forms of cancer, such as cutaneous squamous cell carcinoma, but they do not give rise to melanoma. And so in order to measure mutations in melanocytes, we had to develop a new workflow. And so our laboratory developed this workflow, where we start out by extracting a bulk population of skin cells. And then we single cell sort them so that we now have one cell in a petri dish. And then we try to clonally expand that cell as much as possible. The idea is that all the daughter cells from that founding cell will share the same mutations in that founding cell. Now, these are cells from normal tissues, so they had this limited replicative ability. We couldn't quite grow them out enough to directly sequence them. So to finish the job, we would lyse these colonies of cells, and that would release their genomic DNA. And then we would further amplify that in vitro. And then between this combination of clonal expansion and in vitro nucleic acid amplification, we were finally able to produce enough nucleic acid material so that we could sequence these and measure the mutations from the founding cell of that clone. So if you didn't follow that, the bottom line is we can measure mutations in individual skin cells. Now, I think the value of this information is best exemplified with an example. And shown here is a skin shape biopsy that measures approximately 7 millimeters in its longest dimension. I hope you can appreciate that for all intents and purposes, this is physiologically normal human skin. It's heavily sun-damaged skin, but there's no melanoma, no melanocytic nevus, no cutaneous squamous cell carcinoma, no form of skin cancer or neoplasia here. Now, we genotyped 15 individual melanocytes from the skin specimen, and consistent with it being heavily sun-damaged, the melanocytes had pretty high mutation burden. Some of them were over 30 mutations per megabase. And I want to put this number in perspective. Most solid cancers, like breast cancer, pancreatic cancer, they have mutation burdens between 1 and 3 mutations per megabase. The average melanoma has a mutation burden of 14 mutations per megabase. And so these so-called normal melanocytes, they actually have mutation burdens that are 10 to 30 times higher than a typical solid cancer. And these particular ones even had mutation burdens twice as high as the average melanoma. It was an extraordinary burden of mutations that we did not think could be tolerated in cells of normal tissues. Now, the second thing I want to point out to you is that, again, these so-called normal melanocytes, some of them actually harbored mutations known to drive melanoma. You'll see here these melanocytes that have a BRAF D594G mutation. Critically, this is not the V600E mutation that is so common in nevi and low CSD melanoma. This is another codon of BRAF, and this is actually more commonly seen in the high CSD subtype of melanoma. There were a couple melanocytes with this RASA2 mutation, one with an NRAS mutation, and one with an NF1 mutation. Again, all of these mutations are especially common in the high CSD subtype of melanoma. And then the last thing I want to point out is that many of these cells share some, but not all of their somatic alterations. And the most parsimonious explanation for such an observation is that they likely descended from fields of clonally related cells. So you can imagine that if you have a melanocyte in your skin, and then it gives rise to a field of daughter cells, and then you sequence 2 or 3 cells from that field, they would share all the same mutations from the founding cell of that clone. And then each one would have a private set of mutations that had arisen since the most recent clonal expansion. Now, I cannot say with any degree of certainty how these clones are spatially arranged, but we have drawn a schematic here of how they might have theoretically been arranged. And this is drawn to scale if you assume that the diameter of each field of melanocytes is proportional to the number of cells that share those mutations. So you can imagine that if you're looking at a 7 millimeter area of skin, that within that, you probably have these 1 to 2 millimeter in diameter fields of melanocytes. You can't see them with the naked eye, but I promise you that they are there. So to put this another way, our normal skin is riddled with these oncogenic melanocytes that are invisible to the naked eye. When a dermatologist is doing a skin screen, they are looking for pigmented neoplasms. And when they see that, they think, there's premelanoma, let's watch out for that. But what the genetics is showing is that premelanoma is everywhere, that our normal skin has these melanocytes that have some, but not all of the mutations required to sustain a melanocytic neoplasm. And so when we combine this knowledge with that which we learned from our previous studies of melanomas adjacent to precursor neoplasms, we now know that there are 3 different routes to melanoma. So in this first route, a melanocyte will acquire a strongly activating mutation in the MAP kinase signaling cascade. This will more often than not be a BRAF V600E mutation, and it will result in the formation of a nevus or a mole, a discernible neoplasm. And then if a cell within this nevus gets yet even more driver mutations, eliminating the secondary, tertiary, quaternary barriers to tumorigenesis, that results in the transformation of this nevus into a low CSD subtype of melanoma. Now, the second route to melanoma is for a melanocyte to acquire a more weakly activating mutation in the MAP kinase signaling cascade. And these are the mutations that are most often seen in the high cumulative sun-damaged subtype of melanoma. Now, don't take my word for it that these are more weakly activating. Much more skilled biochemists than I. They've done the bake-offs. They've compared the activation levels of BRAF V600E versus NRAS, NF1, all of these other genes. And generally speaking, BRAF V600E is a more powerful oncogene than these others. And perhaps for this reason, instead of forming a discernible neoplasm, these mutations instead form these subtle fields of melanocytes that are there, but you cannot appreciate them with the naked eye. But if one of these melanocytes gets just a second mutation, let's say a TERT promoter mutation, then that now does result in the outgrowth of a neoplasm, dysplastic nevus, or some sort of an other intermediate neoplasm. And then if it gets a third, fourth, fifth hit, that would eventually result in the transformation here to a high CSD subtype of melanoma. Now, the last route is for a melanocyte to acquire these mutations out of order. So when UV radiation enters a cell, it is non-discerning. The sun does not know where the BRAF gene is located or the NRAS gene, and it will indiscriminately mutate the genome. And so it's possible for a melanocyte to get that second, third, fourth, fifth hit first. And this is analogous to cutting the brakes on a parked car. There's no phenotype immediately, but when you turn that car on and press the gas pedal, so that would be the MAP kinase pathway activating mutation, the car will be out the gate and there is no stopping it. And this explains the evolution of these melanomas that appear de novo. We often call these nodular melanomas. They can be of either the low or the high CSD genetic subtypes of melanoma, and they're notorious for their rapid appearance or sudden appearance and rapid growth. So now we know where these are coming from, but then the next question is, what do we do about them? And I think it's important to take a step back and ask, why do we screen? And the company line is often, well, to prophylactically catch melanocytic neoplasms before their melanoma. And that's a laudable goal, and it's fantastic when we are able to do that. But it's also in our best interest to catch melanomas when they are still melanoma, but before they are a larger and worse melanoma. And I wanted to show you this Kaplan-Meier curve, and you'll note the date here from 2009. I purposely chose an older study because this is before targeted therapies, and this is before immune checkpoint inhibition. And you can see the salient biology of melanoma. And you can see that if you have a T1A melanoma, this is considered a malignant neoplasm, that your 20-year survival is still pretty good. It's over 90%. That's 20 years. It's in 1 year, 3 years, 5 years. And so even if we're catching melanoma when it is melanoma, you want to catch it when it is as small as possible. So to put this in schematic form, you can think about screening in two ways. The first route is to catch these neoplasms that are slowly passing through these precursor phases before they become life-threatening melanoma. Now, the second, these melanomas that appear de novo, they might pass through this field stage, but it would not be effective to screen for these because we can't see them and we have so many of them. But what we do want to do is the moment that they do grow out and form a melanoma is we want to catch them. And I say that with confidence because this has worked in the past. So if you look at the literature and ask, where has there been some success in catching these nodular melanomas, it turns out that most of them are patient detected, 70% of them. Moreover, they tend to be caught earlier in health conscious patients who are more aware of how to properly screen for their own skin cancers. Now, it's challenging to roll out an educational campaign on the population level. And so I have given a lot of thought about how can we improve here. And really it comes down to we need to find the patients who are at higher risk, and those are the patients who we need to target our educational campaigns towards. And being a scientist who has developed these technologies to measure the somatic alterations in normal skin cells, I am working with my institution's industry arm, and we're trying to start some companies where my vision I'll pitch to you is that we could eventually take these small biopsies of normal skin, small enough that it wouldn't leave a scar. These are relatively painful. We could measure the mutational damage in this normal skin and basically just benchmark you against the population. And this would allow us to find the 15-year-olds who their skin still looks great, but if they have the mutational burden of a 50-year-old, then they need to be intervened, and they need to have a conversation about more screening and education for self-screening. But the converse, if you're 50 and you have the mutation burden of a 15-year-old, we wouldn't encourage you to go hog wild or anything, but we would say keep doing whatever you've done to this point. And so we're hoping that we can realize this vision in the future and improve risk assessments. So I told you that we've developed this assay to measure the mutational landscape of individual skin cells. And over the last 6 or 7 years, we've really scaled up these studies to the point where we have now genotyped at exome resolution nearly 500 individual skin cells. And at a high level, the mutation burden of skin cells will vary from one person to the next person, from one site to the next site within each person, and even from one cell to the next cell within each site. I find all of these levels of variation to be interesting and can talk offline with anyone that's curious about them. But in the interest of today's talk, I'm going to discuss how the mutation burden of skin cells varies from person to person, and particularly the role of tanning bed usage and how this shapes the molecular landscape of your skin cells. Now, somewhat surprisingly, studies describing how indoor tanning drive melanoma genesis are somewhat lacking. The World Health Organization does currently classify tanning beds as a Group 1 human carcinogen, but most of the arguments against the usage of tanning beds are based purely on epidemiological associations. And the tanning bed industry has taken that and flipped it around and argued that some of these associations could be linked to other risky behaviors. And in fact, they've even gone further at times to market their products as safe. One of their favorite marketing campaigns is for what they call the pre-vacation tan. The idea being that, let's say you anticipate going to the beach on a spring break vacation. They say to come into the solarium ahead of time to establish a baseline tan so that you are less likely to get a sunburn when you go to the beach. And I think it's just a difficult tightrope to walk, and it flies in the face of the epidemiological association studies. But you can begin to see how they can get away with these claims, and that's because we don't really understand what tanning bed radiation is doing to our normal skin cells. And so to address this gap in knowledge, we established a case control study where we collected skin from cases, which are here defined as extreme tanning bed users, people with greater than 50 lifetime sessions. And we wanted to compare the mutational landscapes of their skin to controls, people that had never experienced indoor tanning. So we established two different control cohorts. The first control cohort came from the exact same high-risk skin cancer clinic as the extreme tanning bed users, and we made sure that they were matched for age, sex, and every other risk factor that we could possibly match for. But here's the problem with this control cohort. These controls are at much higher risk of melanoma than the general population. There is a reason why they are in the waiting room of this high-risk skin cancer clinic. Maybe they haven't used tanning beds, but they probably have high levels of natural UV exposure or a family history of melanoma, maybe even a personal history of melanoma. And so this motivated us to establish a second control cohort, which was skin from randomly selected donors of the UCSF Willed Body Program. So this is a program where you can donate your remains to scientific research after you pass away. And we argue that this is more representative of the general population. But here's the problem with this cohort. We were unable to tightly match for all of these other risk factors, in particular for age. Most of our Willed Body program donors were of advanced age, whereas all of our cases tended to be young women in their 30s and 40s, which is the primary demographic of tanning bed users. So I just want you to keep these caveats in mind as I showed you this data. So I'll cut to the chase. The melanocytes from the extreme tanning bed users have approximately twice as many mutations as the melanocytes from site-matched skin of control donors. In this strip chart, each one of these data points corresponds to one melanocyte. And here we've grouped all the melanocytes from the tanning bed donors and all of the melanocytes from the control donors. And in our paper, we break this down by different control cohorts. We break it down by different donors. We work very closely with biostatisticians to perform linear mixed effect analyses that can tease out the effect of tanning bed use on the background of other covariates. I'm not going to go into all those details. The bottom line is no matter how you cut it, tanning bed usage associates with approximately twofold increase in mutation burden in melanocytes as compared to these control donors. So we've established that the tanning bed users have more mutations in their skin cells than people who have never used tanning beds. We next wanted to ask, do they have different kinds of mutations? And towards that, we performed something that's called mutational signature analysis. So each one of these columns here, this is showing the number of mutations, and then these stacked bar plots are basically a deconvolution of different classes of mutations. Now, SBS7, this is a mutation that has been attributed to UV radiation. And so it was not necessarily surprising that both the tanning bed users and the control donors, they both had a high proportion of cells with SBS7-induced mutations, and there was no difference. But we asked more broadly, were there any differences? And one did pop up. It was subtle, but tanning bed users were more likely to have these SBS11-induced mutations in their skin cells. Now, at the moment, this is a well-accepted class of mutations in the field, but nobody knows the cause. And it's tempting to wonder, given the unique blends and doses of UV radiation that are experienced by tanning bed users, if that might be the cause. I didn't say this earlier, but I'll mention this now. Another marketing claim by the tanning bed industry is they like to say they deliver the safe type of UV radiation. And you might be wondering, what do they mean by that? So UV radiation can be divided into UVA and UVB radiation. UVB radiation is higher in energy and more mutagenic. And the tanning bed lamps will deliver extraordinarily high levels of UVA radiation. And here's what they leave out. They still give you high levels of UVB. It's equivalent to being high noon at the equator. But then on top of that, they give you 15 times as much UVA radiation as can be experienced anywhere on the surface of planet Earth. And so we hypothesized that this odd blend of UV radiation, basically high UVB and supraphysiological levels of UVA, might be inducing these one-off mutations known as SBS11 mutations. So we're still trying to connect a few dots there, but that's our working hypothesis. Now, the last point on the tanning bed topic that I want to discuss is that the melanocytes from extreme tanning bed users were much more likely to have an underlying driver mutation. So we've already established, somewhat paradoxically, that a normal melanocyte can actually have a mutation known to drive melanoma. And the various combinations of driver mutations in melanocytes from tanning bed users are shown here. Here's the driver mutations in melanocytes from control donors. There are actually more melanocytes with driver mutations in the tanning bed cohort, even though we sequenced half as many melanocytes. And that's reflected here when you just look at the fraction of cells with an underlying pathogenic mutation in tanning bed users. It's 25%, 1 out of every 4. So we took skin from the back of these donors, and imagine you're looking at the back of an extreme tanning bed user. There's millions of melanocytes on their back, and 1 out of every 4 of those melanocytes has an underlying driver mutation, meaning that it is one step closer to melanoma. So you just have, basically from the cancer's perspective, millions more shots on goal, where one of these, now it just needs 4 mutations instead of 5 mutations to grow out and form a melanoma. It's not unlike the scenario of familial melanoma. So if you come from a family with a high penetrance of melanoma, you were probably born with a mutation in every single cell in your body that drives melanoma. And so these families essentially are born 4 hits away from melanoma, where the rest of us are 5 hits away from melanoma. So the tanning bed users are simulating this exact same effect just through somatic mutagenesis. So to summarize the tanning bed portion of this study, tanning bed users have more mutations in their skin cells than their peers from a high-risk skin cancer clinic. They also have more mutations in their skin cells than people who are twice their age selected from the general population. They have subtle differences in the types of mutations in their skin cells, and this can possibly be attributed to the unique blends of UV radiation that they experience. They also have a high proportion of their skin cells with underlying oncogenic alterations, and tanning beds are mutagenizing a larger field of cells in natural sunlight, and this is providing this whole body effect that's simulating what occurs in families with a high penetrance of melanoma. So I was encouraged by the reception of this work from my scientific colleagues, but then I was absolutely blown away from the lay media. This did go somewhat viral and was picked up by quite a few news organizations. But I've received some really touching emails from patients and former tanning bed users that really wish that this knowledge had been made available to them back when they made those decisions many, many years ago to use tanning bed devices. And so our hope when this was published is that it would make its way into the inboxes of policymakers who could shape future guidelines surrounding tanning bed usage. I'll mention that in Australia and most of Europe, tanning beds are effectively banned. But here in the United States, it's more of a state-by-state patchwork of regulations. Now, there had been proposed 11 years ago a new rule for the FDA to ban the usage of tanning beds among minors. And after 11 years of debate, we had a bit of a setback in the field. Just last month, the FDA has now killed this proposal. And unfortunately, there was very little explanation. And this came out around the same time as our study. I'd kind of hope that maybe our study might have been the straw that broke the camel's back in the other direction, but somehow it didn't. But on the, I like to be an optimist. One thing that I have noticed over the last year or two is that a lot of patients are diversifying their sources of medical information and are relying not solely on guidance from the CDC and the FDA, and they're reaching out more to their doctors and medical societies for advice. And I know that the American Academy of Dermatology has doubled down on their opposition to tanning bed research. And so our hope is that this still will have the desired impact. Now, I promised that I would talk a little bit about rare subtypes of melanoma. And so I'm going to talk now about acral melanoma. So this is a rare subtype of melanoma that arises on the non-hair-bearing skin of the foot sole, the palm of the hand, and the nail bed. The cell of origin for acral melanoma is thought to be a melanocyte that's buried deep in the sweat gland beneath our calloused hands or calloused skin. And hence, UV radiation is not thought to be a major etiological factor. You might be thinking, well, the palm of your hand does sometimes see the sun, but because the cell of origin is beneath the calluses and we have pretty thick skin, it does not seem to be a major factor in driving the formation of acral melanomas. Now, like cutaneous melanomas, acral melanomas do have similar pathways that are mutated. They often have these MAP kinase pathway activating alterations, activation of telomerase, disabling of the G1S checkpoint, but the specific genes involved could not be more different. And that's illustrated in this, what we call a tiling plot from one of our papers. Shown here are all the different oncogenes that we discovered in the setting of acral melanoma. And then here, each one of these columns is a different tumor. So you can see the various combinations of mutations across tumors. And you probably don't recognize most of these gene names because these are very different genes than the ones that I talked about earlier, driving acral melanoma versus cutaneous melanoma. But if you have a keen eye, you might notice at least one similarity, this BRAF gene that seems to be in both. And we were curious about this, and we looked more closely at these particular tumors. And when the pathologists scrutinized these further, they looked more like the low cumulative sun-damaged subtype of melanoma. And then I'm a geneticist, and when we sequenced them, this small subset actually did have UV radiation-induced mutations, whereas all the other, what I like to call true acral lentiginous melanomas, they did not. And then there's this final kicker that only white people seem to have these BRAF V600E mutant melanomas on the palms of their hand and soles of their feet. And recently, the study came out in Mexico. Mexico is a very admixed population. If you just grab someone at random, they could be 95% Northern European or 5% American Indian ancestry. And they found that these BRAF V600E mutant melanomas on the palms of the hand exclusively arose in people that were predominantly of Northern European ancestry. And so we now believe that this is a contaminant pool of melanomas, that this is probably low cumulative sun-damaged melanomas that just so happen to arise on these body sites. And so it does show the danger in a classification system of melanoma that is based purely on anatomic sites. And this is not a purely academic question because you would want to know this. If you happen to have a low CSD melanoma on an acral site, you probably have a high mutation burden. You would be more likely to respond to immune checkpoint inhibitors. You probably have a BRAF V600E mutation. If it came to it, you might consider that as an option. Whereas the truer forms of acral lentiginous melanoma have fewer effective treatment options. So these true forms of acral lentiginous melanoma, they don't have these UV radiation-induced mutations. So what is instead driving them? There must be some fuel to the fire. And they're driven by this unique type of structural variation. It's called a hailstorm. Others have called them typhonas. And shown here is a copy number plot. And if this was a cutaneous melanoma, you'd see a purple line that would just be straight, probably indicating that there's maybe a gain or a loss. But I hope you can appreciate just how chopped up this is. And essentially, acral melanomas, they shatter their chromosomes, and then the cell doesn't know how to glue them back together properly, and it results in these extraordinarily complex structural variations. This has only ever been observed in one other cancer subtype, dedifferentiated liposarcoma. It's kind of random, and I have not yet deduced the connection between them. But this is the defining feature of acral lentiginous melanoma. And the research community is working hard to try to find some vulnerabilities that can specifically kill these types of cells that harbor these hailstorms or typhonas. Now, our laboratory went back to the same tried and true methods that I showed you earlier to infer the evolution of acral lentiginous melanoma by sequencing fully evolved melanomas adjacent to their precursor neoplasms. Now, for acral melanoma, an invasive acral melanoma tends to grow out of a melanoma in situ, which itself could grow out of these fields of clonally related melanocytes. So acral lentiginous melanomas rarely grow out of common nevi. So we sequence these different stages of neoplasia. And this is just a high-level overview of the evolution of acral melanoma. So the first step is the formation of these occult fields of melanocytes, and they tend to have these hailstorms. We know that this is an early event, what we like to call in cancer biology. These are truncal events, and if you look broadly across all cancers, most effective therapies are targeting truncal events, and this is the reason why we're working so hard in the research community to try to target these hailstorms. I hope to have in the future some more positive results on those studies. But after the formation of these hailstorms and this occult melanoma in situ, you can now see melanoma in situ once there's activation of the MAP kinase signaling cascade, and then these other pathways become disrupted, fueling the outgrowth of an invasive melanoma. And one scary feature of acral melanoma is their extraordinary levels of genetic heterogeneity. You can have half of a tumor with one mutation and the other half with another. And so even if you have a druggable mutation in this cancer subtype, if it's not truncal, it's probably not going to be especially effective. So to summarize the whole talk, melanomas arise from the accumulation of somatic driver mutations. And on average, it takes approximately 4 to 5 different driver mutations that are disrupting a key set of signaling pathways. The order in which these driver mutations occur will influence the progression trajectory of the ensuing melanoma. These mutations can also occur out of order, and this explains the evolution of melanomas that appear de novo. We also talked a little bit about tanning bed radiation and how it drives melanoma, and it does this by increasing the mutation burden of your skin cells, by inducing somewhat different types of mutations, and by mutagenizing a larger field of melanocytes than natural sunlight ordinarily would. And we talked a little bit about acral melanomas. They are really fundamentally different from cutaneous melanomas. And so you want to get these diagnoses right. And there is always the possibility, if you have a melanoma on an acral site, that it could be a low CSD subtype of melanoma. But that can be rooted out with good histopathology assessments and or genetic profiling. So with that, I'll acknowledge everyone that made this work possible, in particular my colleagues, Boris Bashin at UAA, who have been instrumental in all of these studies, and Meng Wang and Vishal Tandikar, 2 trainees that I've worked with that led several of these. So with that, I'd be happy to field any questions.
All right. I learned a lot from that talk, and I do every time I hear Dr. Shain speak. I'm going to start with a couple from the chat, and then we have microphones that will circulate around. There were two different questions from the chat that I'm going to summarize. The tanning beds study provoked a couple questions about, one about the risks or impact of red light therapy, which has become quite popular as a kind of alternative or supplementary treatment for a variety of things. And then a comment about, is there any reason to think that UV exposure at a nail salon would be somehow different than tanning beds? So we'll start with that question.
Yeah, two great questions. So I like to stay in my lane, and when a future speaker dermatologist comes up, if I'm saying anything totally wrong, jump in. So my understanding is that red light is not especially mutagenic. Of course, anything in excess does potentially concern me, but I'm not aware of any high quality epidemiological studies that have linked this to mutagenesis or skin cancer. But again, please correct me if I'm wrong. As far as the nail bed, that's a fascinating question. There was these nail beds, they deliver extraordinarily high levels of UVA radiation. I've never really used one of them, but I'm told that it's supposed to harden this, the surface of your nails. But people have actually taken skin cells and put them in these nail beds, and it clearly mutagenizes them, and it induces these reactive oxygen species type of mutations. And so, I don't know if the epidemiologists have yet seen an epidemic of, fingertips, cancers in these patients, but they do alarm me. I can't stand up here and say with any confidence that that's a safe practice. But sharp question.
To the back, in the middle.
Thanks for such a great presentation. And I have actually two questions. So the first one is mutations are associated with all kinds of cancers. You're looking at the skin, but I'm curious if we've established, is there like a human high mutation phenotype that puts a person at generally increased risk of cancer? And, are we going to get to a point where you can sequence the human genome, assess if you're one of these people, and then have higher surveillance for all cancers going forward?
Yeah, great question. And the answer is yes. You can find people with mismatch repair deficiencies. For whatever reason, they're more likely to get colon cancer, but they get a wide variety of cancers. People with germline P53 mutations. P53 is called the guardian of the genome, and if you have a germline P53, you can imagine that the cells in your body are accumulating mutations more rapidly. Another great example might be xeroderma pigmentosum. So now you have a defect in the cell's repair machinery that's specifically designed to repair UV radiation-induced mutations, and they basically cannot walk outside without getting cancer. Those are the extreme cases, but you can walk this back a little further, and just by having light skin tone, we lack the protective effects of melanin, and our skin cells are accumulating mutations more rapidly than people with dark skin tone. And so there's a million examples of showing that based on your germline heritable polymorphisms, that influences the rate of various cells accumulating mutations. And so, yes, I think that having your DNA sequence, can basically tell you your risk of lots of different cancers.
Yeah, one other quick question. People are always going to want to tan. Is there a way to stimulate a melanocyte to get darker without harming UV radiation or damaging DNA? Is anybody looking into that?
In the laboratory, yes. Unfortunately, the chemicals that do that effectively struggle to penetrate the stratum corneum and have not been, rolled out, in a clinical use case. And so I'm trying to fight against this. The first thing you said, people want to get tan. I just hope we can move on from that. I don't think that is an obligate, trend moving forward. If this, we can start in this room, but if we can fight against that. So.
Just to build on that, to your question, the first question, in the clinic, the way we identify those high-risk patients is usually from a strong family history or a very unusual personal history where someone may have been diagnosed with multiple cancers, early age. And so we kind of find those people those ways. Now, that's a little bit reactive because you're responding to things that have already happened in the personal or family history. But those patients get referred, and we kind of try to understand why they seem to be at a higher risk for cancer. And sometimes we find out why, and then that can affect their care and the care of other family members.
Thank you for asking that question. My late husband had the NRAS mutation, and blonde hair, blue eyes, and both of our children are blonde hair and blue eyes. And I was told that they're at higher risk. Is there anything that can be done other than the fact that they just go to their dermatologist and they're checked out? I mean, is there any advancement in that as far as the genetic profile?
Yeah, so the NRAS mutation was probably somatic, meaning that your husband was not born with that. It acquired in one melanocyte and drove that, but it probably acquired because of his light skin tone and poor tanning ability. And it, unless your dermatologist has flagged your family as being of high penetrance, and Evan just talked about some of these. It doesn't mean that's untrue, but it's they're probably at higher risk because of their poor tanning ability. And for them, see the dermatologist, be screened often, but learn to self-screen, avoid sun as much as possible. Use sun protective measures. Without knowing any more details, I think that's a solid armamentarium for them to prevent. But sometimes it's just a bad luck disease, and it sounds like that might have just been what happened with your husband. I'm sorry to hear that.
Well, we're in our 70s.
Yeah.
We grew up before the sunscreen.
Yeah.
Thank you for your information here. Growing up in the Northwest as a skier and a sailor, and with Irish skin, I'm really susceptible to, and I'm finding that I'm getting these melanomas now. My best course is, of course, high SPF factor sunscreens, because I'm still going to sail, and of course wearing hats. Although hats are kind of funny because I've had my ear lobe worked on. It's really hard to live in the Northwest and avoid sun completely.
Yeah.
And plus, there's no base tan, which you're telling me is really not, there's no advantage necessarily of having a base. So the sun tanning, the SPF shirts, the wide brimmed hats are your best case to prevent. So just avoiding the sun altogether. Is that what you're saying?
It's not practical to avoid the sun altogether. And, I don't want to be shrill and ever, say that advice. But to the extent that you have, control, like me personally, I try to run 5-6 days a week. I prefer to run early in the morning, later in the afternoon when the sun is at a more less steep angle, and the rays are not as extreme. But I'll still run at noon if it makes sense. But in that scenario, I really try to coat myself with sunscreen. And so I personally just try to always make a quick calculated decision, like, okay, based on what I'm doing right now, what should I do? And I'm not going to coat my entire body in sunscreen to take out the trash for 5 minutes, right? But if I do know I'm going out at high noon, especially on a boat or skiing, like that is a scenario where unequivocally it is worth the 20 extra minutes of prep to just put on that hat. Sometimes they have these little ear flaps that'll cover, and to really double down on the sunscreen, like make sure you don't miss any spots, right? So, but for your mental health and exercise, go outside. I'm not going to say stay inside in your closet all night.
Yeah, I have a question, and it's in regards to like outside pollutants that might affect the skin. And the reason I ask is we lived in Uravan, Colorado, which is now a sign on the highway, the Superfund site. But my dad would come home and we were guessing that uranium dust would just drop on the floor. So my dad's had melanoma, my mom's had it, my sisters have it, and I have it. And we're wondering if it could be traced back to uranium dust or something
Yeah.
that might be on our skin. And does that lead to other pollutants in the air that might affect mutations on the skin?
Out of curiosity, if you or your family members had other forms of skin cancer, or just, other forms of cancer, or just skin cancer?
Skin cancer, melanoma,
interesting.
amyloidic skin cancer.
Okay. So in theory, any mutagen can cause skin cancer, right? In my personal experience of sequencing lots and lots of different skin cancers, it's like 99% of the time, UV radiation is the unequivocal, driver mutagen. But it would be fascinating, particularly if there's clusters. It sounds like your family is a cluster, but if your community, if this is a broader effect, to do some scientific studies and see if there's some sort of connection there. But the reason I asked about other cancers is I would expect, if it was uranium, that it might drive lots of different cancers. But maybe the short answer is that any mutagen can drive any cancer if it's exposed to those cells. So. All right, are we running out of?
One more question in the middle here.
Thank you. I was wondering if a lifetime accumulation of x-rays, dental x-rays, head x-rays, scans that you get yearly, all of that accumulation, if that has any effect that you know of on the occurrence of melanoma. Thank you.
Yeah, if there's an epidemiologist talking later, maybe you can comment. But in the same vein as the previous question, any mutagen can cause, any cancer. And I personally have started opting out of, X-rays sometimes at the dentist. Instead of once every 6 months, I might do it once every 2 years. But more generally, I mean, almost all cancers increase in incidence with age, and that is because as we age, we have been exposed to lots of environmental mutagens, and it's not just our skin cells, but all the cells in our body have accumulated mutations. And so, to the best of our ability, we should, while still getting our exercise and maintaining our mental health, we want to try to avoid mutagens. For skin cancer, UV radiation is clearly the strongest culprit, but all these others are important to avoid too.
Wonderful. Well, I really appreciate your talk. We clearly had a lot of great questions from the audience, and what a great way to start today. Thank you, Dr. Shain. So, next up, it's my privilege to welcome Dr. Katherine Jackson, who some of you may know and some of you maybe haven't met yet. She is an assistant professor in our Department of Surgery at UW School of Medicine, Fred Hutch. She graduated from medical school at Dartmouth, completed general surgery residency at the University of Rochester, and then a fellowship, additional training in surgical oncology at St. John's Cancer Institute. And then we were fortunate to recruit her here to join our melanoma program, which we've been very excited about. She's also the recipient of many awards, including the Dale Hahn Memorial Scholarship Award from the Sentinel Node Oncology Foundation. And she's now been a member of our faculty and a valued colleague for about 18 months. So I let you get 18 months in before I hit you up to speak at our event. So she's going to talk about minimizing scars, evolving surgical treatment of melanoma. Thank you, Dr. Jackson, for being here.
Thank you for that introduction. And then, do I just press this to go forward? Or the mouse? Mouse, okay, gotcha. All right. Okay, so I have no financial disclosures. I am surgical oncology trained. I am not a plastic surgeon, but I did a lot of training in oncoplastic techniques and like to incorporate that into my practice as well. And we'll talk about that a little bit today. And I wanted to start with a patient story because really that's what this is all about. So this patient came to me after her dermatologist biopsied a right leg pigmented lesion, and it came back as melanoma. And I really wanted to walk through how we think about this. So right off the bat, it's a collaboration between the surgeon, the dermatologist, and the pathologist who's looking at the melanoma under the slide. And there's many different features, as you may know or remember, that are reported on that biopsy report, like 8 to 10 features, including the stage. The two most important things, arguably, are the Breslow depth and the presence or absence of ulceration. So We know that tumors that are deeper or have a greater Breslow depth are more likely to spread, they're more likely to come back. Same with tumors that have ulceration. So those, we get so much information from that initial biopsy, and that really guides what we do going forward. So if you've ever been in the surgeon's office after a diagnosis of melanoma, you know that a lot of our talk is about the removal of the tumor and also the management of the lymph node. I don't have time to discuss the lymph node today, so we're going to focus on the removal of the tumor, and that procedure or surgery is called a wide local excision. And then I also want to focus on the reconstruction. So how do we close it? We'll talk about different options, where the field's moving, how do we customize it, and why this matters. So melanoma as an entity has been described since the days of Hippocrates, and if that name sounds familiar to you, all of your physicians have taken a Hippocratic oath, same guy. And then it was known that the melanoma acted more poorly than the other types of skin cancers, the squamous, the basal cells. But it wasn't really until 1907 that anyone proposed a solution as to what to do about this. As we're standing in Seattle, I just feel the need to mention 1907 was also the year that Pike Place was founded, so 400 years ago. So Dr. Handley introduced this concept of a wide excision, a removal of a large amount of tissue, as well as a removal of all of the surrounding lymph nodes. And we just got a great talk about this, so that was a perfect setup for this slide. So you have the abnormal melanocytes and the melanoma arising from one of those. And actually in the 70s, well before a lot of the sophisticated measures that we just saw, they knew that there were abnormal melanocytes at least 4 centimeters away from the tumor, and that the melanoma kind of extended down. So if you think about the layers of the skin, epidermis, dermis, those yellow bubbles are really supposed to represent the fat below the skin, the subcutaneous fat. So when we're talking about the removal of the tumor, the depth doesn't change, and it's not based on a measurement, it's based on the skin layers. So we take the top layer of the skin and the subcutaneous fat all the way down to the muscle. We leave the muscle alone, and we leave the protective covering over the muscle called the fascia, but the depth is really determined on those layers. In contrast, when we're talking about the surgical margins, we're talking about the measurement from the tumor, or oftentimes just the biopsy site. So how wide of a rim of normal tissue are we taking? And that has thankfully evolved over time. So back when Dr. Handley was describing this, again, we knew that we really wanted to clear as much tissue. We wanted to prevent the melanoma from coming back. So the initial proposal was to take 5 centimeters of margin around the tumor. That's 2 inches around. And just to put that in perspective, for about a 1 centimeter biopsy site, which is relatively small, that's the size of a softball of a removal of the tissue. So that was the original description. And thankfully, we had trials coming after that. And a lot of the gold standard ways that we move forward in the field of medicine is to do something called a randomized trial. So patients, in this case, who are presenting with melanoma, randomly assigned to undergo a 5 centimeter margin or 2 centimeter margin, or in a different trial, 1 versus 3, to really compare as best we can apples to apples. And in all of these head-to-head studies, we actually found that taking more than 2 centimeter margins didn't actually prevent the melanoma from coming back. And it didn't increase survival. So today, fast forward to 2026, these are the standard recommendations. So for those thicker tumors, those deeper tumors, we still recommend the 2 centimeter margin. For the thinner tumors, we actually recommend taking even less tissue, so 1 centimeters. And in between, this is our cancer guideline. It's up to the discretion of the surgeon and the patient, and it often depends on different factors that we'll get into. So the recommendation for those intermediate tumors, like our patient, is for 1 to 2 centimeter margins. Because we don't know if this matters from a cancer standpoint. We don't know that taking 2 centimeter margins will prevent the cancer from coming back. But we do know that the size of the margin very much matters to our patients. And kind of intuitively, from thinking about all of those studies, so patients who had a 2 or 3 centimeter margin had a higher surgical complication likelihood, that a higher chance that their wound would break down. And then oftentimes those patients with the larger margins had a higher chance of needing a skin graft or some kind of advanced reconstruction. And we'll get to those momentarily. But they also had an impact on their quality of life. So not just the visible scar, but patients who had a 2 or 3 centimeter margin had a poor mental and physical function. and a poor quality of life immediately after surgery at 6 months compared to those who got the 1 centimeter margin. Luckily, because as we just said, we still do take the 2 centimeter margins. At 1 year, that kind of evened out. There was no quality of life difference. But again, early on, patients really experienced a decreased quality of life. And then persistently, so even 2 years after surgery, patient who got the wider margins did have a higher scar dissatisfaction, greater scar. So fast forward to today. So this study is still ongoing. It's going to require thousands of patients, but what we're trying to do is now take these deeper tumors or tumors with ulceration and randomize patients to 1 or 2 centimeters. Because again, we know that taking more impacts our patients. So assessing if the patients with 2 centimeters have a longer survival, higher chance of recurrence, things like that. So that trial is ongoing and we'll probably have answers in about 2037, I think is when the first report is supposed to come out, but stay tuned. So getting back to our patient, so you can see this is kind of a tricky spot, right? It's near her knee. There's not a lot of surrounding tissue to pull together. And I can't say definitively that taking a 2 centimeter margin is going to, again, prevent this cancer from coming back. So we elected to take a 1 centimeter margin. But how are we going to close this? And really the question we're trying to answer is, how do we close a circle? There's a lot of considerations. So the margins that we just talked about, skin laxity, how well does the skin move? Can it come together? Location, of course, a melanoma near the eye is going to probably close very differently than one on the arm or the back. And of course, patient goals and preferences. And could absolutely give a whole talk about this concept called the reconstructive ladder. And that really means that there's different ways to close a defect, all the way from just leaving the defect and letting it heal from the bottom up. That's called secondary intention. You can imagine the wound is open, has poor cosmetic outcomes, and all the way from very advanced plastic surgery techniques. But I wanted to talk about the 3 most common ones that we use today. So primary closure, skin grafting, and then something called an adjacent tissue transfer, which we'll get into. So primary closure is the ideal way. But it still can be a little striking. So if you think of making our margin and turning it into a football or an ellipse and closing it, you still end up with a decent sized scar from this seemingly small lesion. And this is why, because we're trying to clear that and bring everything together. This is the fastest way to heal. It usually takes 1 to 2 weeks. It's color matched. And then it has relatively minimal scarring and a lower chance of infection because we're not just letting the wound heal. And just to demonstrate this, so the patient on the left, these are both patients with upper arm melanomas, upper right arm melanomas, coincidentally. But the patient on the left has a thin melanoma, so we recommended a 1 centimeter margin, and the patient on the right had a thicker melanoma, so we recommended a 2 centimeter margin. These are not to scale, but you can kind of imagine that their final scars will heal differently. So the gentleman on the left had this done in the dermatologist's office. It's not going near his elbow, even though it kind of started close, and it's a lot smaller. And the patient on the right had this done in the operating room because it's a large area to numb up, and it takes up her whole arm. So even though they healed nicely, we got everything together primarily, you can still see the difference that 1 or 2 centimeters makes. And we're not always able to do this. So the next kind of least complex thing we can do is something called a skin graft. And the skin graft has been around for a long time. It's very effective. We can cover large areas. It's relatively simple to perform. But there are some downsides. So you have to take a piece of skin from another part of the body. So that's 2 surgical sites you have to heal. We talked about that depth that we take. And if we're putting a thin piece of skin over that depth, you can get a concavity. The color is the color of the skin that it came from, so it doesn't always match well. And then you can have a decreased sensation over that wound as well. We have been able to mitigate some of these downfalls with the usage of a skin substitute. So what this is a wound covering, and you can kind of see the defect in the wound, and the skin covering is kind of filling in the whole volume. This was originally designed in patients who were undergoing treatment for extensive burns when they didn't have enough healthy skin to immediately skin graft. So it was used as a bridge. And we still do that today, again, to kind of minimize the defect and to increase the success rate of grafting. So without the skin substitute, the risk of graft success is about 80 to 90%, but you can still have failure of the graft. And that's the success is increased with the skin substitute. And then what we find in a lot of our melanoma patients is we actually can just kind of let the wound heal that way. It's covered, so low chance of infection, and they don't need a second surgery, and you spare them the morbidity of a second site. So I just wanted to walk through one of the patients who we use a skin bridge for. There will be some kind of immediately after surgical pictures, so if you get a little squeamish like my mom does, just look away for the next 30 seconds. So this is a 20-something-year-old patient with melanoma of her right foot, and this is one of the acral subtypes. So we wanted to do the 2-centimeter margins. So in those layers in that area of the foot where we went down to the tendon, which is what this white structure is here. So not a lot of soft tissue in the foot, and you can see that concavity on the side. So we placed the skin substitute, and you can see that she healed really nicely from underneath. So her own body filled into that matrix, that scaffolding with the skin covering, and was able to fill in the volume of the wound. And then we were able to do a skin graft. And this is her foot. She just sent me these pictures yesterday. So this is her kind of updated. And in terms of a cosmetic outcome, it's not perfectly color matched. Luckily, this wound will continue to remodel for 2 years usually. So it will look better. The other downfall of the skin graft that was very evident in this patient was you have to be immobilized. So you can't move your foot. You really want the apposition of the graft in your foot. But now she's walking, running, she's building her muscle mass, and she's doing very, very well. I spoke to her yesterday. Yeah. And then the last kind of more typical way that we close things is something called an adjacent tissue transfer. Now, that's either sliding tissue over or kind of swinging it in, but you're bringing all of those layers with you, the skin, the subcutaneous fat, so you're kind of filling in the concavity. Compared to grafting, patients who get reconstructed with this method, and again, it's not always possible, but have a higher cosmetic satisfaction, color and contour matching. It's more successful than a skin graft, and it's a single stage operation, so we're not doing the delayed reconstruction. Again, the ideal way would be primary closure, but we can kind of demonstrate how those may not be possible. And then importantly, you get preserved sensation too, so you can still feel that skin, and it should return to normal. Sorry, I meant to warn again. But to how to close the circle, so this was a patient who had a 2-centimeter margin, again, on her forearm, and we could have skin grafted, but the tissue wasn't able to be pulled together, mostly because of constricting of the arm. So we did what's called an O to Z flap, where we rotate everything in, kind of like a hurricane. So this looks a little gnarly right now, but this will all flatten out to a nice straight line. She'll have color matching. She won't have a defect there. So expect her to heal very well. And then for this gentleman, has melanoma of the cheek. Now, these skin edges could come together, but then you're going to pull the eye down, you're going to pull the ear forward, which are not desirable things. So we make a facelift incision and can do something called a cervical facial flap, where we actually take the cheek and move it up. And you can see that the face normally heals very, very well, and this is only 1 month after surgery, and is healing well. So for this patient, again, we could, even with the 1-centimeter margins, we're not going to be able to close this primarily. It's near the knee, so she would have to have her whole leg immobilized for weeks while this is healing. So we elected to do something called a keystone flap, another local advancement flap. And what that is, if you can kind of imagine, this orange spot is removed, and then you actually slide a whole island of skin and the subcutaneous tissue, and the blood supply is coming from underneath. I keep hitting this. And we were able to do that and slide it over, and then you're able to cinch the other part of the leg where there's a little more laxity. And this is what it looked like 2 weeks after surgery. You can see it's a little swollen, which is normal. But this is what she healed like. So 6 weeks later, and then 7 months again, compared to a skin graft, really great color matching. And again, this will continue to remodel and look better over time. So. And then I can't give a talk about minimizing scars without actually talking about scar treatment. So number one thing you can do is sun protection. Not only does it cause skin cancer, it actually delays healing and can make the scar permanently pigmented, which is not what you want. There are a ton of gels and creams and vitamins and things out there. There are randomized trials showing that the silicone gels or sheets, if used regularly for a few months, does result in scars that are flatter and less pigmented. And those results kind of show up 6 to 8 months later in those studies. And then if you're prone to hypertrophic or keloiding scars, so that some patients just naturally get very wide or very tall scars, you can use corticosteroids to help flatten them and make those less apparent as well. So it's amazing that we're talking about survivorship today. We've come so far from the days where we're just taking more tissue and hoping everyone makes it through. And I really think this concept of, thrivership, like really moving on from that index cancer visit is important. And we know from the talks we've seen, melanoma kind of demands that we take some wider margins that we know of now, but if we take really wide margins, we're putting the patient at risk of complications, complex surgeries, and maybe we don't have to take as much tissue for the same outcome. So we want both quantity and quality of life, and love that we're talking about this today, because minimizing the morbidity of all of these cancer treatments really is a part of cancer care. So, thank you.
All right, wonderful talk, thank you, I learned a lot. That's, I couldn't do it via surgeon, but it's cool to look at the pictures.
You could if you wanted to.
So, any questions for Dr. Jackson? Got one in the back.
Thank you so much for doing that. That was so awesome. For those of us who have no origin spot, this all seemed very topical, like when you have the melanoma that you can see. For those of us who haven't been diagnosed until it was already in our lymph nodes, do these same modalities of surgery apply to those locations, or are there different ones for, the surgeon who's doing it for inside of the body?
Yeah, so that's a great question. So if we don't have a primary tumor, then we wouldn't subject the patient to surgery to try to, find a different spot. I think your question becomes relevant too if you did have a primary spot and a lymph node. We also probably wouldn't want to take the 2 centimeter margin. So the whole point of doing the wide local excision that I didn't really touch on is to prevent the cancer from coming back in that spot. So if it's already gone to the lymph nodes, we probably do want to clear that area and prevent it from coming back. But of course, we're more worried now about the systemic aspect and the treatment of the lymph node, which has also evolved, which maybe next year we'll chat about that. But yeah, great question. Yeah.
Down a few rows.
So you've shown us different ways of solving the problem. And I assume the one where you bring this living skin over, there's less nerve damage. Mm-hmm. But are these evolving techniques? Are there other new techniques on the way?
Yeah, so that keystone flap is probably one of the newer ones, although when I say new, it was developed in 2006 was when it was first described. The other ones, skin grafting is very, very old. In terms of skin or nerve sparing, there's not really much in the way of the local flaps because either the flaps come through or not. And with the skin graft, with the excision, we're removing all of the nerves in that area. So you either have to bring in skin with its own nerves or not. And the skin that you bring in from a skin graft does not have the nerves with it. The only thing I can think of that's analogous is like in breast surgery now they're exploring nerve sparing mastectomies, but there's not a lot of evidence because nerves really are not great at healing. So it's really hard to bring nerves back together. And even if you do bring them physically together, they don't function normally. So they're definitely looking at it in multiple different fields, but I don't know of anything that has actually worked. Yeah, but great question. And it really is an important part too. That sensation is a big deal. Yeah.
Oh, I see, okay. All you doctors are great and our GPs are great, but be persistent when you find something that is suspicious. We've had experiences ourselves where the doctor says, oh, it's just a barnacle or it's just this or just that. You have to pursue it. If you don't give up and don't be embarrassed. Say, but I really think it's something serious. Anyway, that's my comment.
No, that's
Make sure you persist with the doctor.
Yeah.
Please do something about it,
Yeah.
even though they don't think it is.
Yeah, it's a great message to advocate for yourself because, everyone comes to work trying to do the best that they can, but sometimes the message, that communication, it just isn't always there. So absolutely agree. Advocate for yourself and your loved ones, and
And don't be embarrassed. Do it.
don't be embarrassed. Yes.
I have a question that may be combined, pulling together the threads from the first two talks. So Dr. Shain kind of suggested to us that when we look at melanocytes nearby to a melanoma, that they are often abnormal and maybe have acquired some of the features that would lead them to become their own melanoma. And it just makes me wonder, we sometimes see recurrence in the area of surgery that we think is a recurrence of the original melanoma, like as a satellite lesion, that term we'll use a lot, or in transit. And then it's also possible that people could develop a new melanoma in that area. And I'm just wondering if you think that, kind of an additional benefit of the margin is that this is an at-risk zone for melanoma, period.
Yeah, I had that thought both ways. I'm like, oh, because I almost had the study up here, but basically the one that showed like the 4 centimeters away from the primary tumor were abnormal, but we know that taking 4 centimeter margins doesn't clear it, or else the patients that had 4 centimeter margins excised would have done better. So yeah, maybe we still should do wide margins, or maybe it's just all abnormal and we should just be taking the primary tumor.
Hunter, I know you thought you were off the hook, but I'm just going to ask, given you have these new technologies, would people who have what we would call like a local recurrence, so a recurrence of melanoma very close to the surgery, even though they had margins, do you think there's value in testing to see if this is the same melanoma genomically, or maybe a different melanoma just in an at-risk area?
Yeah, I mean, you could easily root out this question just by going back in the archival tissue, sequencing the original excision, and then the new supposed recurrence, and you could deduce whether they are phylogenetically related. Definitely a worthwhile study. I mean, we've even seen, it's not common, but instances of a melanoma that we thought was growing out of a nevus, and they were not always related to one another. So you can certainly get collisions, that's the term we coined, of skin neoplasms in this. If you have a lot of sun damage, the whole field is at risk, and it's not necessarily the same tumor that's recalcitrant.
Very interesting. Food for thought. I'm going to mull on this over the break. We have time for a couple more questions. If anyone
Hi
has
there.
Oh,
So when you talk about the face, right, there's usually maybe a Mohs surgery done and then a closure of that. And then there's different types. These are either basal cell or squamous or maybe melanoma. When you talk about those, so a couple things. When you talk about the differences between the type of cancer that there is and then the margins that you should take based on the type it is or whatever, and then the area in which you have to close it with maybe an eye in the way or a lip in the way, is there a when you talk to like 3 different plastic surgeons, they might say, oh, I'm going to do it this way, or I'm going to do it. They might have 3 or 4 different ways of closing that hole based on what is in the way. Is there any kind of general decision on, okay, this is, if you do it this way, the lips or the eye is going to be impacted this way, and that's better than if it's impacted this way? Like, so what's kind of the decision process of how you close something when you're talking about the face, which is a little bit more personal than if you're closing something on the back?
Yeah, absolutely. I will say it's kind of twofold. So one, I never take 2 centimeter margins on the face, even with thick tumors. There's just no evidence that like disfiguring this person is going to prevent the melanoma from coming back. Like that's a very risk-benefit thing, and absolutely talk to the patient about that. And then near the eye or lip, sometimes we even take like a 7 millimeter instead of a 10 millimeter margin. So these are like man-made things, not based necessarily on biology. In terms of the face, there are a few problems with closing that you want to avoid at all costs. So The lip, if pulled up, that can be released later on. If the eye is pulled down, it's a very difficult problem to solve. It's called ectropion, and you can get eye dryness and everything. It's a very, very difficult thing to treat once it's happened. I can't think of a scenario where like we have to choose, but there are certainly like very critical things that we want to avoid, and specifically avoid in that way. So I think you would probably balance like the different like dreaded complications. But usually we don't have to pick because there are a lot of really great ways to close things in the face too. So. I would avoid the lip if it was not immediately involved with the melanoma. Yeah. Yeah. And same with the eye. I've taken 5mm margins on the eye to not go into the eyelid. Yeah. Yeah.
I have maybe one last question if anyone, we probably have time for one more if there's one, but looking ahead, let's say I ask you to do this again 15 years from now.
Yeah.
What, if you were going to predict something that you think might be different than just looking ahead? I'm not going to hold you to this, but I'm just curious how you might imagine things being different 10 to 15 years from now.
I think we're going to not take 2cm margins once we've never say never. I don't think we've ever done a study in surgery where taking more tissue helped. Like we know that surgery is curative, but in terms of like taking more, I would be surprised if the 2cm margin group did better, just based on what we've seen and based on what we've done today, because now I'm like the whole skin is just at risk. And then, so Melmart will be out. 15 years is going to be good because MSLT3 will also be resulted by then. So yeah, there's a few things, but I think we're going to see a lot of surgical de-escalation, and I'm actually pretty confident of this because, again, melanoma just kind of follows breast cancer around, and we're like omitting sentinel nodes or taking less tissue and all of these very high risk cancers that we thought we had to do more for, but we have more systemic therapy and everything. So surgical de-escalation.
At a high level, it seems, and you're right, that there's been a lot of learned from the breast cancer evolution. It seems like initially the trend is towards very thoughtful and carefully deployed surgery, with the idea that more extensive surgery could be done later on if it seems like it's the right thing for the patient, instead of a very extensive early surgery for everybody. It's kind of the philosophy seems to be changing. Would you agree with that?
Yeah, absolutely. And we've seen that in the melanoma lymph nodes too. So I think MSLT2 came out in 2014, where we used to, if you had an arm melanoma, you would have all the lymph nodes removed under the arm. And then we started doing the sentinel nodes. And then if you had a positive sentinel nodes, we would remove all the lymph nodes. But we showed, and this is before immunotherapy was really adopted for most of those patients that did not have the completion lymph node dissection and later had a recurrence didn't do worse. So finding that disease later really didn't seem to be detrimental. So we do know that we have more time. And again, now we have effective systemic therapy, so maybe even less of an issue.
One more here in the middle. Here, Melissa, I'll hand you my microphone here.
I have a loud voice.
Okay.
Oh, I think it's for the people on virtual land.
You avoided, for a reason I'm sure, not to get into the lymph node question.
Oh, yeah, but I love talking about lymph nodes, so we kind of.
But picking up on his addition, would you say the future is to take out less lymph nodes then in the future?
Yes, short answer.
Fewer. Yeah.
So with the sentinel node, in terms of the number of lymph nodes that we take out, it depends on your body anatomy. So if you injected my arm with a radiotracer, I may have 2 lymph nodes that light up. Dr. Hall may have 1. It depends on your body. So for the sentinel lymph node procedure, that's kind of a set standard. But in terms of doing a removal of all of the lymph nodes, we are seeing that procedure done less and less.
So it depends on the location of the primary
in the location
mole, let's say, if it's on the back.
Yeah, and that may map to both underarms.
How many lymph nodes are there under each arm?
Like 40-ish.
Oh, okay.
Yeah. But even the removal of 1 to 3 increases your risk of arm swelling, 3 to 5% chance of arm swelling, even with the removal of 1 to 2 to 3. Yeah, it's
Dr.
not a zero
Hall
risk.
Jackson, one
Oh,
last
yeah.
question here.
Oh, sure.
Great talk. I have a skin graft on top of my head, and a couple weeks after they did it, they called and said the margins were not clear, and I had to go back and have more removed and have it kind of done again, another graft taken
Yeah.
off my thigh. These, you're talking the previous one, both fantastic talks make me wonder, what criteria were used to determine that?
Yeah, so it's, again, they probably just followed that set margin, that wide local excision. I would say on the scalp, that's my number one place to use that skin substitute for this reason, so that you don't have to regraft. And those are the ones that have healed pretty well primarily, so we don't always go back and skin graft now. And if you have to add a little more skin substitute, that's a lot more tolerable than having to redo the graft.
So they look at it under the microscope and they see too many of something? Is that,
So that would probably be the
Okay,
abnormal
yeah.
melanocytes, yeah, at the edge of the tumor. It's really hard to discern that between, and that was the lentigo that we were talking about. Do you remember the subtype? It's a quiz. No, okay. Yeah. OB-RAF wild type, yeah.
All right. Well, we are pretty much on time, which is I think the first time that's ever happened in the time I've been running this. So we're going to thank our first two speakers. We're going to go ahead and get started so we stay mostly on schedule. Want to make sure we have as much time for questions. The questions and engagement from the audience have been awesome so far, so keep those coming. I always tell the speakers it's the most fun part is the back and forth with the audience, and I feel that way about this year's program already. So for the next talk, it is my privilege. I have to do two introductions because we're going to try something kind of exciting and have a dual talk. So this is pretty cool, or I think it's exciting. So it's my pleasure to welcome two of my UW Fred Hutch melanoma colleagues to the podium to give this next presentation. We'll start by introducing Dr. Natalie Miller. Dr. Miller is an assistant professor and melanoma medical oncologist, so she works closely in our melanoma medical oncology group with me and is a wonderful member of our team. As you notice, she is a double doctor, so that's a long path and a lot of hard work to do both the medical degree and the PhD. And during her PhD, she actually studied immune mechanics of skin cancer, focusing mainly on a different skin cancer called Merkel cell carcinoma. But she really brings a remarkable understanding of the science, things like we heard from Dr. Shain this morning, and the clinical together. So she's pretty unique on our team in that way. So we're really excited to have her here. And secondly, I'll introduce Dr. Josiah Hanson, who's an assistant professor at UW in the Department of Dermatology, as well as in the Department of Lab Medicine and Pathology. So he is both a dermatologist and a dermatopathologist. So he sees patients, helps manage skin conditions and diagnose them, and examines specimens under the microscope. And that is a way in which he is invaluable to our team, a major contributor to our melanoma tumor board. And as an aside, he also is the director of the medical student clerkship in the Department of Dermatology. And he is also, we learned recently, a houseplant enthusiast. He has a tremendous number and variety of plants in his home. It's quite remarkable. So if you like plants, he might be someone you talk to over lunch. So they're going to give a co-presentation entitled Your Immune System in Action as we move from this early melanomas to patients where we're trying to harness the immune system to fight the melanoma. So Doctors Miller and Hanson, thank you so much for being here today.
All right. Good morning, everyone. I'm very happy to see lots of faces that I know and new faces as well, and I am so glad to get to talk to you. Just a little overview. We're going to talk about melanoma and your immune system at a high level and how we use these relatively new medicines called immune therapies to try and improve some of our patient outcomes, especially for earlier stage melanomas. Then Dr. Hanson will take over and talk about melanoma under the microscope, how we're measuring our responses, and then talking about a new, again, not new, but increasingly used strategy called TVEC, which is an oncolytic virus to try and stimulate the immune system in melanoma. All right. So Dr. Jackson, who you just heard from, is obviously a fantastic surgeon. The challenge is no matter how good your surgeon is, the melanoma can come back, even when you have an early stage 1 or 2 or even 3 melanoma that is taken out, if the cancer cells have already migrated away from the site that we can see. Average chance that the cancer comes back over 10 years is very variable. If you have a melanoma that's limited to the skin, maybe a stage 1 thin melanoma, the chance is very low. However, if you have an advanced stage melanoma, maybe stage 3, where it's gone to various lymph nodes in your body, you have a much higher rate that it could come back after surgery, up to 75% or so if you have many lymph nodes involved. So obviously, we want to stop those recurrences if we can. And to do that, we're predominantly using the immune system that you all already have working in your body. We know that there are these T cells that travel around that are one of the most important cells in your immune system. They're important for finding cells in your body that have been infected by viruses and bacteria and killing those cells before they start to cause problems. But the T cells not only can recognize these pathogens, but cancer cells as well. That's because your melanoma will express little bits of mutated proteins, those proteins that get mutated by sunlight, on their surface, and so it can look like it shouldn't be there to your immune system. So in a great, perfect world, we get these T cells, they infiltrate the tumor when they sense that there's something that shouldn't be there, and then they release these little granules, these little grenades in a way that can actually directly kill the cancer cells themselves. Now, if you're saying, well, if our immune system can do this, how do we end up with melanomas in the first place? And that's because, unfortunately, the tumors are quite smart. The tumors have developed a mechanism to hide from our T cells by sending these off signals. You can think of the T cell as having a little hand out there, its little T cell receptor, and it's searching for that foreign protein, shown here in blue, that it sees on the surface of a melanoma cell. Once it makes that contact, this very, very specific handshake, where only a small fraction of the T cells in your body are able to do this, then it sends the signals to kill your melanoma, and we're all happy. But your melanoma can express these proteins called PD-L1 on its surface, and that essentially interacts with another protein on the surface of the T cell called PD-1 and turns off the T cell. We actually do call it exhaustion. So it's like the T cells are there, but they're taking a little nap and they're not able to do their job even if they see your melanoma. However, medicines that you might be familiar with that target either PD-1 or PD-L1, like Keytruda or pembrolizumab or Opdivo or nivolumab, those come in and they just block this interaction. It's a physical block. So this signaling can't happen anymore, grenades get launched, and the melanoma dies. We've been using these immune therapies for metastatic or stage 4 melanoma for over a decade. The first one came out in 2011, but more recently, in the last 10 or so years, we've started using them earlier and earlier. The idea is that can we use immune therapy to sop up any of the cells that get missed or left behind after a surgery and kill them so that melanoma never comes back? So this is an example of a trial in which patients were given, after their surgery for stage 2 or stage 3 melanoma, they were either given Keytruda or pembrolizumab for a year or a placebo medicine. And then they were watched over a period of time. This graph shows out to 2 years or 24 months to see whether the cancer would come back. This graph shows the fraction of patients where the cancer has not come back. So at the beginning, when we're starting, everyone's 100%, and you want to stay, ideally, as high on the curve as you can. And you can see that the patients who got Keytruda for a year had a less chance that the cancer came back. This has been replicated in other studies with other drugs. So both Keytruda and Opdivo are approved in this setting for anyone with a stage B melanoma or higher, where we think that the chance of a melanoma coming back is high enough, and using these medicines is worth the squeeze to prevent the chance. It's roughly about a 50% reduction in the recurrence risk from what you started with. But importantly, we haven't seen that this changes the survival of our patients, just simply the chance of whether the melanoma will or will not come back. That was, you might have seen like 2018 or so, and that's very routine standard practice now. But more recently, the last few years, we've been focusing on how to even do better than that. And the idea is whether using immune therapy before a surgery can actually do a better job. So this schematic shows you just what I talked about. We have a patient with a tumor. Dr. Jackson or her colleagues remove the melanoma. We give the immune therapy, and we hope that these little multicolored T cells in here get activated, circulate through the body, and kill anything that's remaining. But by using immune therapy before a surgery, we hope that we could activate many different types of immune cells in a stronger situation. And then after the tumor is removed, we have a more robust immune response that does a better job at preventing the cancer from coming back. I'm going to show you a couple of patient photos from this in action, patients who've agreed to have this shown. So on the top, I have the before photo and then the after photo of after someone has gotten a couple doses of immune therapy. And it might be challenging to see, but this was a raised melanoma on the patient's scalp. He got a haircut, but the melanoma also shrunk a lot, significantly. And then another example of the melanoma loves the scalp, right? So we see this big pigmented lesion that just completely went away nearly after immune therapy. And then another spot on the cheek. This is one dose or 3 weeks after an infusion, and you see that completely go away. So in addition to the kind of overall benefit that we talked about, we also think that it could potentially make surgery a lot easier. But we still do a surgery because, as Dr. Hanson will share with you, we get a lot of information from looking at the tumor after that. So when we think about how well this works for not just the patients I showed you, but populations as a whole, we do see that immunotherapy before surgery can reduce the recurrence risk even further. In this clinical trial, patients were randomized 50-50 to either get immune therapy before and after surgery, shown in this blue line, versus just after surgery. And then in this case, again, we're looking at whether patients stayed without the melanoma coming back. Everyone starts at 100%, and then ideally you're staying up. So in this group, again, at 3 years, it was 75% of those people were without a recurrence, compared to maybe 50% or so. And again, the responses seen in the tumor are helpful for determining our long-term prognosis. And with that, I'll transfer to Dr. Hanson to show you some fun photos.
All right. Thank you, Dr. Miller. That was spectacular, and I am learning so much already today from all of these talks. And there's a lot of things in my life that I'm really grateful for. One of them is just being here and having this opportunity to share some time with all of you. I'm really grateful that I get to spend half my job looking at skin, treating skin, trying to find these cancers early. And I am incredibly grateful that I get to look under the microscope, because I think that this is beautiful. And I was talking with Dr. Hall earlier this morning, saying you can just give me a slide and I can talk about it ad nauseum. So forgive me if I need to be held back as we go here, but I really love teaching about histology. And I get to do the first year introduction to histology for a lot of our medical students, which is really fun. So most people don't look under the microscope at all. Probably a lot of this looks unfamiliar to a lot of you, but you can look at yourself and see what we're seeing on the slide here. So to begin with, we have a punch biopsy, so this is deep. The outer layer of the skin here is what you can feel with your finger against the back of your hand. We call that the epidermis, and epi means on top of. So this is the outer layer of your skin. Underneath that, you have the dermis, and a good example of this is if you feel your back and you have that firmness on your back, that kind of leatheriness, as you might say. That's really that deep connective tissue that holds you together. That is most of the skin on a lot of the body. So these are our two normal parts so far, but there's something abnormal going on here, which is a tumor. And in this case, it's melanoma. And you can see it sticking out like a sore thumb. It's not supposed to be here. It's not growing normally. It's forming this large nodule, and it's growing very irregularly. So we're going to look a little bit closer to get some of the finer details within this tumor. And what we're seeing around the outside is the body fighting against this tumor, trying to wall it off. This pinkness here is called collagen or fibrosis, and that's a wall that the body is forming around this tumor. But the tumor is expansile. We have a lot of words we like to use in our pathology reports that you may see if you ever read through them. But this is an expansile proliferative nodule of very atypical cells. You can get a hint of what they might be over here because there's a little bit of brown pigment. So this is the melanin that the melanocytes make. They don't always make that, but it's frequently there. And if we go a little bit closer, we can get some of the finer details of what melanoma can look like. I think even to someone who hasn't looked under the microscope much, you may agree that these are irregular. So some of these cells are big, some are small, and they're very blue. And under the microscope, we call that basophilic. And blue is the machinery of mitotic activity or cell division or growth. So that's DNA, it's the nucleus, it's everything that's involved in growing. And these cells are full of blue, so they are full of the machinery to grow. Some of these are mitotic figures. They kind of look like ants. And there's tons of mitotic figures throughout this. There's a lot of variability in the size. They're just kind of ugly. So this is what cancer or melanoma often looks like. These cells are not normal. So if we were to look at melanocytes in the outer layer of the skin, you can tell what they are just with a routine stain, which is what we have here. But when they're behaving poorly, they don't look like melanocytes anymore, so we have to use a special stain. This is called a SOX10 stain. The specific name isn't too important, but it highlights the nucleus of melanocytes only. So the background tissue here is undyed tissue, and it just looks kind of grayish blue. But anything that is, in this case, kind of this dark brown color, or sometimes a red color, is specific for a melanocyte. And importantly, it's pretty specific for a living melanocyte. So once they are dead, they no longer stain with these special stains. When we are interpreting these reports or these slides, there's a lot of stuff to look at under the microscope, but we try to digest it into something that's relevant for the patient, for you, and for other people who are treating patients. So we grade the pathologic response, and especially in the setting of immunotherapy that Dr. Miller was teaching us about. We look at how much of the tumor was killed or had an effect from that treatment. What we hope for is a complete pathologic response, which means 0% left, 100% dead, however you want to say that. So that is 0% of that tumor that was alive and positive with those stains before is now dead. We also have a partial pathologic response, which is up to 50% of the tumor is still alive. So that's still great. It still means that it is working and your immune system is killing the melanoma. There's just some of it left. And we call a non-response, doesn't mean 0, but it means less than half is killed. So those are the 3 different grades. And I'm sure many of you have looked at these reports. We have a lot of very esoteric terminology. I think we kind of make it hard to understand what we're talking about, and it's an area of interest of mine of how do we really express what these mean in simple terms. So we've tried to simplify how we talk about this treatment effect. And as a group at UW, we've come up with this relatively small and understandable table saying this is how much tumor is left. This is how much is dead, which is necrosis. And then we talk about some other things that are a sign of the immune system or the body fighting, which is inflammation or fibrosis. And fibrosis is basically a word for scar formation. So this is how we grade the response to treatment. And what does treatment look like? Well, it can look a lot like melanoma itself. So looking at this, you might be hard-pressed to say, is this 100% alive or 100% dead? But there are some clues even from this far away. If we look at these areas in the center, this kind of homogeneous pinkness, you remember that blue is the sign of machinery of replication. And when a cell is dead, it loses its DNA, the nucleus breaks apart, it is no longer blue, it's no longer basophilic, and we call this eosinophilic. Eosin is just the name of the stain that gives the pink color to these slides. So these are big areas of necrosis. Chemetonecrosis, we call it, or just regional geographic necrosis, which is a good thing to have. We also have the immune system here. These really blue cells here are our lymphocytes, or these are immune cells that come in, and they are essentially just a nucleus. They basically have no cytoplasm or that pinkness. So they're super blue, but this is a good blue because these are the ones coming in and doing some damage. And we can look a little bit closer to get some of those details. Looking at much higher power here, we can really see these necrotic cells here. So these are old, dead melanocytes. These ones have no machinery left. They're losing their borders. They just kind of look like these pale pink globules stuck to each other, and that is 100% dead. Over here, though, we can still see some blue, and we also can see some pigment. So these tiny little granules in here, that's melanin, and that gives you a good clue that these are melanocytes, and they're not normal, so that would be a melanoma. But these are in the process of dying, which we call apoptosis. They still kind of look alive, so we have to do some special stains to determine if these are really dead on their way or are they totally fine. And in this case, we did a special stain and there's no darkness here at all. So all of those areas that we saw in the previous special stain that showed the living nucleus of those melanocytes are gone. So even though it looks relatively similar, the special stain is totally negative, and this tells us this is 100% dead tumor or a complete response. This is important because the degree of response tells us how long a person is going to go without having recurrence of their melanoma. So what we're looking at here is not survival in terms of life and death, but how long after treatment do people go without having the melanoma come back anywhere. And the degree of pathologic response predicts the real life response, how long someone's going to go without having melanoma coming back. So the top line here, as Dr. Miller was helping us out, 100% is where we want to be. You want to stay up there, 100% of not having it come back. And if you have that major pathologic response, 100% dead tumor, 1 out of 20 people only will have recurrence, in this case, over about a 2 or longer year history. But a partial response is still really positive, so that still means a lot, even though it's not 100% dead, at least in the sample we looked at. So patients who have had a partial pathologic response, which is up to 50% of the tumor is still alive, 1 out of 4 patients over this whole period would have recurrence. So 75% don't, which is great. People who do not show that pathologic response, so we look under the microscope and the tumor before looks the same as the tumor after, there's really not significant change, are much more likely to have recurrence of their melanoma, which is this bottom line. So that's an overview of what the histology looks like, why we are grading, and what it means for people who have cancer. But there are other ways that we can harness the power of our immune system. And this example is TVEC for metastatic melanoma. On the next slide, I'm going to show you what that word means, but I have a bit of a joke, and I'm from the Midwest, Minnesota myself, so no offense if anyone's here from the great state of Minnesota, but I have a very flat Minnesota tongue. So it's really hard for me to pronounce a lot of words, and TVEC is a good example of that, so we're just going to stick to TVEC for this. It's quite a bit easier. But T-VEC is used in people when they just have too many melanomas that we can really treat with surgery. So, for example, this patient, you can imagine, and it was really fascinating seeing some of those surgical pictures, but if you have melanomas that are on your skin, you can see them with your eye and probably feel them with your fingers, but we're not going to cut this out. Each one of those would be a large excision. It's just not feasible. It's morbid. It's not a nice thing to have happen to you. So T-VEC can be an option to treat this type of melanoma. There's the word for T-VEC. I won't try. But T-VEC basically is a engineered virus, actually a herpes simplex virus, and I underlined the root there of herpes. And if you've ever had a cold sore, you know how your body feels about this virus. So this causes a lot of inflammation and anger and death in infection. So we've tried to harness this terrible thing, which no one wants, to have benefit. And the goal of this is not only to kill the tumor by getting some of the virus inside of it, but to also harness our body's immune response like we'd have to a vaccine against your own tumor. So we take the injection and we inject it into one of those areas, or as many as we can, that are visible or palpable, meaning we can feel them on the skin, and they get infected with the virus, and then the virus replicates. So the tumor is still there, but it is full, chock-a-block full of virus. And what happens next is the infected cells that are now full of virus get killed by the virus, and they break apart into lots of little pieces. We call those antigens, and antigen just means piece of something that the body can recognize. So you have tumor, you bust it up into millions of pieces, and each one of those is a signal and tells the body what the tumor looks like elsewhere. Then our immune cells come in, and they recognize those pieces. They make something called an antibody, which I love that term of grenade. So something that the body is making that recognizes tumor, and it's specific from this tumor that got blown up by the virus. And what it does is it makes our immune cells able to see uninfected tumor. So you've injected one tumor, it gets killed directly by this virus. It releases its pieces, and that targets the immune system to attack the tumor that is not injected, and potentially is not even close enough to the skin that we could inject it. So this has a virtuous cycle of antigen release, pieces release, primes the immune system, and the immune system goes in and kills the tumor. So that's the general overview of how T-VEC can work, and it's really great in the right cases. So here's a clinical example on the left. These are all melanomas. So dozens, sometimes hundreds, maybe even thousands of tiny melanomas in the skin. Clearly, we're not going to go in there and cut all of those out. It just wouldn't work. So we inject, which is where they injected with these arrows, and you do multiple treatments. So you get more and more of these virtuous cycles going. And then 1 year after treatment, it's almost normal skin. One thing we know is melanoma makes melanin. Melanin is pigment, and once you have it in your skin, it doesn't go away. So we still see outlines of where these tumors were because they were making a pigment that stays in the skin potentially forever. It can get stuck there. And it's hard to tell with the eye, is this a response or not? So we take a sample and we look at it under the microscope. Here's another example of skin with the outer layer here. The dermis, which is the thick connective area. We have some normal fat tissue here, which all of us need to have at the base of our skin, so that's normal fat. And then we've got a lot of stuff going on in the center. Number one, we have all these blue cells, so these are the immune system. These are lymphocytes that are coming in. They're responding to T-VEC, they're killing off the tumor, and this is where the tumor was. And you can tell it was there because it was making melanin, and you can see a ring of that melanin that's left behind, and that'll be there forever, or at least quite a long time. In the center, we have more of that homogeneous pink stuff, which is necrosis, or a dead tumor. And around it, we have fibrosis. So this is all the signs of the active immune system with an acute process, and then the chronic immune response around the tumor and dead tumor in the center. And we confirm it by doing a melanin or a melanocyte stain, and all you see is that pigment. It's really brown, so it's always there. You can't bleach it out really. But we don't see any of the specific findings of melanoma left behind. So a couple pictures just to go a bit closer. It's always nice to see the positive effect of our treatments. So this is a time when we like to look at things that have died, and this is dead melanoma. Pigment all around there, pink dead in the center, immune system coming in to do its work. And we can even go a bit closer to close up this portion of the talk with what I think is a really pretty picture of all these different areas of melanin, fibrosis, dead tumor, got some lymphocytes around the side. So this is really what we're trying to harness. And we don't usually get to see what's happening inside of our bodies, even if our treatment is working. But this is a good example of what it looks like when we successfully kill melanoma. So thanks for your time, and love to answer any questions.
You now know a lot more about pathology probably than you did when you started. I'm still learning. I may know just enough to be dangerous now. I don't know. So we got some hands raised. I'm sure this is going to inspire some questions.
Thanks for a very interesting talk. And it got me thinking, we live in a day and age where tattoos are everywhere. And I've often wondered, first of all, is getting inked carcinogenic from a skin cancer perspective? If it's not, does it impair our ability to make a diagnosis early enough to positively impact treatment outcomes? What should people be told about getting tattoos and skin cancer?
Yeah. I love that question. I think it's really fascinating. And the answer is complicated. I'll share something slightly private. My wife has quite a number of tattoos. She loves tattoos. Everyone in her family does. When done correctly, they are safe. The challenge is there are very few regulations as to what goes into the ink in tattoos. So 20 years ago or so, we had our basic tattoo ingredients, and it literally was ink, very similar to what we use on paper. There were some fascinating things like cinnabar, which is actually mercury, that makes a red ink in kind of traditional tattoos. And in the US, there's few regulations. It's not regulated as a drug or a medicine. It's considered a cosmetic process, even though we're injecting it into the body. And now a lot of the pigments are literally like car paint. You can inject lots of different things into the skin. A lot of it is safe, but we don't know for all of it. So not a simple answer, but it has potential for causing some trouble, but it depends on what the ingredients are. And as a consumer, it's almost impossible to know what those ingredients may be. One fascinating thing we see a lot actually in the skin is when we look at lymph nodes that people have taken out for melanoma, I can look at a lymph node and tell you the color of your tattoo on that arm, because your body will pick up that pigment and go to your lymph node, and it is full of pigment. So it definitely is present, and your body responds to it. And people, after they get a tattoo, will often have sore lymph nodes afterwards, and that's your body recognizing that a foreign material has been injected into your tissue. So it'll cause a response. And I certainly know, as a dermatologist, all skin is beautiful and fascinating. Some of it is easy to examine, some of it's more challenging, and generally a lot of tattoos can make it quite challenging, especially if we're looking for a pigmented lesion, because you have saturated the skin with pigment and you're not going to see subtle changes in a little bit of melanin here and there. So you're often looking for bumps, and many people know that our body makes lots of bumps. Most of them are totally safe. They're normal, we all make them. So we have to have clues like our microscope, a little pocket microscope, or color, and that gets taken away if you have a tattoo. So it can make it more challenging. It's a really good question.
So, I have a lot of tattoos, but regardless, I'm going to try to be as PC as possible on this question because the immunotherapy is one of my most favorite things and one of the things I hate the most. It's like a double-edged sword, right? Like we know that it's doing good stuff, but at the same time, the side effects can be completely terrible and they suck. Yes, double doctor, this one's for you. Okay, so this might be really dumb to ask, but why in the heck do different people get different responses to the same immunotherapy? And what the hell can I do to stop feeling like crap?
Yes.
Please and thank you.
Yeah. What a wonderful question. I so wish that I could answer that for people. I wish that I could look at someone when they come in the office and we're thinking about doing immune therapy, say, what is the chance that you specifically are going to have a bad side effect? It all depends on your immune system. It's very, very nuanced, but we talked about how there are certain T cells that can recognize the melanoma, little bits of the melanoma as foreign, and we want to activate those immune cells. But you have other immune cells in your body, everyone does, that have been intentionally turned off. That whole PD-1, PD-L1 signaling pathway was put up on purpose to prevent people from developing Crohn's disease, rheumatoid arthritis, type 1 diabetes. So naturally, that's a protective off switch. But unfortunately, the drugs that we give reactivate all the exhausted immune cells in your body. And so if you had a predisposition to getting something bad, we unfortunately unleash that when we treat your melanoma. So in the stage 4 metastatic situation, we talk about these risks and benefits, and the benefits we think outweigh the risks. But we're not giving every person with a melanoma immune therapy for these small tumors, stage 2A, stage 1 tumors, because of these side effects. So, yeah.
This was along the line of the tattoo question. With tattoos, they use lasers to break down the ink so that your lymph system, I believe, can then take them away or kind of help process them out. Have lasers been looked at in regards to melanoma treatment, or are we anticipating advances in that type of therapy to maybe help mitigate surgery or other areas to treat melanomas?
Yeah, another really good question. Lasers are really powerful, and they can destroy tissue. That's how all of them works, and they all need to have a specific target. So for example, if you're treating like wrinkles on your face, you have a wavelength of your laser, and it has to match the resonance or how the target vibrates. And in that case, we're targeting water. So most of your body is water. So that type of laser will destroy any tissue that is human, as long as it's still alive, because it's full of water. So you have to be careful. When we're targeting pigment, we do have lasers that can target melanin. So you can decrease the pigment in the skin, or actually what this is used for is to remove hair. So hair removal lasers work by targeting the pigment at the base of the hair. It heats it up to like 2,000 degrees, and that kills the hair, which is why you actually can't remove non-pigmented hair. So if you have white hair, you're out of luck. You cannot use a laser to get rid of it. The challenge with that is, unlike immune therapy, we can't target a laser to a specific antigen, like one thing that's specific to a tumor. So lasers cannot target cell types like that. So they can destroy tissue entirely, which is what we're kind of doing in surgery very carefully, but they can't specifically target a cell. At least we have no way of doing that yet. But it is relevant for melanoma that we have some trouble, because people don't like their moles sometimes, and they also don't want scars. So usually to remove a mole, you have to cut it out and you get a scar, and that's inevitable. You always have a footprint left behind. But some people will just bleach their mole by targeting the melanin, so they make it white. That's great if you just don't want to look at your mole, but that also means that if melanoma comes from that mole, it will not make melanin, because we've killed the melanocytes that are producing melanin and only leaving the ones behind that aren't. So we lose most of our signs on how to find melanoma if you use lasers to treat melanocytes. So it actually causes a bit of trouble when we're trying to find melanoma.
We have time for one more question for this duo in the back. Sorry.
Yes, thank you. I was diagnosed with stage 1 melanoma, very teeny tiny, in 2011. and it was removed, and it did not go to my lymph nodes. Fast forward 13 years later, in July of 2024, I was diagnosed with metastatic stage 4 liver and brain cancer. Thanks to immunotherapy, as of October of 2025, I am cancer-free. So, which is great. Yeah, which is great. What I want to know is the tumor DNA that I had in 2011 was the same as the tumor DNA that was in my liver and my liver. I don't know really about the brain, but where did it hang out for 13 years? Because I didn't have any other occurrence of skin cancer.
Yeah, great question. You defied our odds. You know, we think that patients with stage 1 skin cancer have a very low chance of it coming back. We typically watch people, not even in my group, we don't even see a medical oncologist. So we're not doing scans. We think the chance is low, but every once in a while, unfortunately, your story happens. As far as where the melanoma has hidden, that's a great question. You know, the liver is in fact an area of the body where the immune cells don't do their job quite as well often. You know, and someone like you who's had 14 or so years between the first melanoma and it coming back, it suggests that your immune system did actually participate in, it did its job. It was trying to get your melanoma to not grow. And it had a battle for, 14 years until your immune system lost. And then it got reactivated pretty easily with the immune therapy. I say easily knowing that obviously it was not that way for you, but you had a great response. And so it's impossible to really answer your question. We think that somehow a couple cells just survived that battle. Yeah.
Thank you very much for a very interesting presentation, for really interesting questions. Fascinating questions. I hadn't even considered some of those things. All right, so we are going to proceed with our second of our keynote talks. So it's my distinct pleasure to welcome one of my melanoma medical oncology colleagues from elsewhere, Dr. Sunandana Chandra, who is an associate professor of medicine at Northwestern Feinberg School of Medicine. So Dr. Chandra is a very well-known medical oncologist around the country and the world in melanoma care. She also, among her many roles at Northwestern, directs the hematology oncology training program, the fellowship program there. And she's a tremendous collaborator. She's a part of basically every large, impactful study, many of which we just saw slides from, that has changed how we have moved melanoma care ahead, including the use of immunotherapies for high-risk patients. So kind of building on the theme, she's going to focus on what's next or what might be next in melanoma, which I think is an important thing to think about. Where are we headed? So it's a great pleasure to welcome Dr. Chandra for her talk, Emerging Therapeutic Strategies for Advanced Melanoma.
Quite a bit shorter than Evan. Hi, everyone. First of all, I have to say I'm so impressed that all of you guys are here on a Saturday morning of what's a beautiful day just to spend some time with us and to learn a little bit more about this disease. So kudos to you guys. I feel like I'm in an unenviable place because I'm standing between you guys and lunch. And so my hope is that the next, 40 minutes or so will be helpful and hopefully informative. Okay, so give me one sec. Let me just make sure I do this. Okay, these are my disclosures. So today, we're going to briefly touch on the cancer immunity cycle and immunotherapy, thanks to my colleagues previously. Hopefully, you guys have a better understanding of how these drugs work. We'll then talk briefly about clinical trial development and the evolution of clinical trials. And I've been tasked today to talk to you about what's coming down the pike, or potentially what might be coming down the pike. So I'll give you some primers on what's standard, but then the bulk of the talk will be really focused on some new advances that might be coming our way. Sorry. Okay, so this is the cancer immunity cycle. So what does this mean? So in any person, this cycle should work properly. So you have your melanoma tumor here, down at the bottom. It's in gray. Our natural immune system, our innate immune system, acts upon that tumor in a very non-specific, antigen-independent way, we call it, to try to kill those cells. And these immune cells are macrophages, natural killer cells, and they result in some cell death. When that cell death occurs, you have these neoantigens, which are pieces of the tumor tissue that are spilled as the cell dies. Those neoantigens are then picked up by this green blob, essentially, which is, it's called an antigen presenting cell or a dendritic cell. These actually present these bits of the tumor, these neoantigens, to these blue cells called T cells that have been previously alluded to. These neoantigens activate these T cells. These T cells then become essentially trained to identify these bits of tumor tissue that is specific to that person. Those T cells then basically go out into the into the vasculature, back into the sites of wherever the tumor may be, and this time in a trained fashion, in an antigen-dependent fashion, can cause cell death. So when this works, we do a good job of eliminating cancer cells. And then in addition, the scientific and medical community have thought of different ways to augment this further. So for example, bottom left, chemotherapy, radiation, targeted therapy causes more cell death. You have vaccines that help prime the antigen-presenting cells. You then have immunotherapy that was previously mentioned, these anti-CTLA-4 drugs and these anti-PD-1, LAG-3 drugs that work in these various compartments to make our immune system actually be able to kill the cancer cells. So let's go into this a little bit further. Again, my colleagues have done a really good job in describing this, but I think it bears repeating. So you have this dendritic cell showing a neoantigen to the T cell in blue. When that happens, which is actually depicted by this little yellow circle, it activates the T cell with the number of other signaling pathways that are activated. Great. You want that T cell to be activated. You want it to be able to kill the cancer. All is well. Same thing on the right. In the tumor microenvironment, you have the T cell and the tumor cell being bound together, and that's how the T cell kills the tumor cell. Again, this is exactly what we want. We want those T cells to be active. We want them to eventually kill the cancer. However, as has been previously just said, cancer is smart, and there's a lot of mechanisms that have evolutionarily evolved in deactivating that T cell. So for example, these inhibitory receptors such as CTLA-4 here or PD-1 here are expressed on the T cell, and when they bind their partner, that T cell shuts down, which is exactly what we don't want. Now, someone asked a great question before of side effects. When you shut down the T cell, those side effects lessen, but then also cancer killing lessens, right? So then we've developed these monoclonal Y-shaped antibodies to bind these inhibitory receptors, preventing them from binding their partner and thereby keeping the T cell active so that it can do its job in killing the cancer. So we talked about CTLA-4 depicted in this kind of teal color. We talked about PD-1 depicted in this I don't know, fuchsia color. But another target that is now being used in melanoma is LAG3. So all of these, you guys can imagine, are very important in this immune synapse between T cells and antigen-presenting cells and tumor cells and inhibitory immune cells called myeloid-derived stem cell cells. These are basically, this cartoon is to show us that there are various targets that are involved in the activation and inhibition of our immune system. So let's take a little bit of a different path in our talk now. So how do clinical trials work? How do clinical trials work to then lead to the approval of all these drugs we've been talking about? Pembrolizumab, Keytruda, nivolumab, Opdivo, nivolumab and relatlimab, which is Opdualag, nivolumab and ipilimumab. So essentially, it starts all in a laboratory. We have such amazing scientists who are spending hours and hours of their life in a laboratory to understand mechanisms that might play a role in cancer development and in fighting cancer. We then all work together, plan a trial, we think of the hypothesis, we work with our statisticians, we figure out what are the objectives, what are the endpoints of this trial. And that really matters at the end to understand if that trial is successful or not. Once we have done that, we then have a particular drug go through different phases of a trial. So phase 1 in the bottom left, you're studying a new drug, and honestly, you're just looking at, is this safe to give to a person? Phase 2, you're not only looking again at safety, but this time you're trying to understand, could there be a little bit of a hint of activity in cancer with this particular drug in question? Phase 3 is kind of like the big phase trial. These are usually hundreds to over 1,000 patients, where you're comparing, hopefully, that investigative drug that you have in question compared to the standard. And then phase 4 occurs once the FDA has approved it. They're still looking and collecting data to see if there's new safety stuff that come up, safety signals, long-term outcomes, et cetera, et cetera. And all the drugs that we've mentioned so far have had to go through this process for the most part. Okay, so now we're going to briefly talk about an advance in post-surgical or adjuvant melanoma in people who have positive nodes, or they have stage 4 melanoma, but it was fully surgically removable or resectable. Now, the standard here, you guys, is a year of immunotherapy, one agent, a PD-1 agent, for up to a year, and that has shown to reduce the risk of the melanoma recurring by about 40%, which is significant. The question is, can we do better? So that's where this mRNA 4157 personalized vaccine comes into play. So let's talk about this for a second. So basically, everyone has a tumor that has a particular mutation signature. We've talked a lot about that this morning. That particular mutation signature leads to specific proteins being produced. Those are called neoantigens that essentially the tumor cell expresses. And that is very different from one person to another. So what this trial did is they took a person, let's say a stage 3 node positive person. The person underwent surgery with our surgical oncologists. So they underwent a wide local excision, they underwent lymph node removal, and then it was sent to a facility. In that facility, they looked at that tumor specimen and they tried to identify up to 34 tumor-specific neoantigens that are very specific just to that person. Up to 34 neoantigens were identified, and they were then packaged into an mRNA strand. What is mRNA? So DNA, as you guys know, is essentially the blueprint that makes up all of our bodies, and all of our DNA is a little bit distinct from each other. mRNA, so imagine DNA is the cookbook itself. mRNA is just one recipe, and it's a strand that allows our body to build one protein based on an mRNA signature. So, back to this trial. They took up to 34 neoantigens that are very personalized to that patient's tumor. They packaged it in an mRNA strand. They put that mRNA strand in a lipid nanoparticle. Then they shipped it back to the patient's hospital, and then that patient could get it as an injection. So how was the trial designed? So this was a 2-to-1 randomization. It was a phase 2 trial. So 107 patients were randomized to receiving the mRNA vaccine plus pembrolizumab or Keytruda, and 50 patients just received pembrolizumab alone. It was open label, so everyone knew what everyone was getting eventually. And the primary endpoint, meaning the statistical question, was, does this reduce the recurrence? Okay, so one of my thoughts was I wanted to present the data to you guys to show you what we look at when we evaluate these trials as we're thinking of these trials for our patients. So characteristics are important. So median age of these patients ranged from 61 to 63. They had an excellent performance status. Why is that important? If a person comes to me who's very frail, perhaps not able to be as functionally active, then perhaps translating this trial data to that person may not be ideal, right? Or, for example, most of these patients had stage 3 melanoma. If a person comes to me with stage 2 disease, I should not be looking at this trial for that person in front of me. So the baseline characteristics really do matter. So we talked a little bit about these curves. So basically, on the left, the x-axis, which is the vertical, shows the recurrence-free survival. The y-axis, which is on the horizontal, shows time in months. So this is basically showing us how patients do over time. And remember, the higher the curves are, the more have survived. And so in a nutshell, the patients who received the vaccine and pembrolizumab, depicted in green, had a higher recurrence-free survival compared to those who just received pembrolizumab. That was the primary endpoint, and it was statistically significant. On the right, this is distant metastasis-free survival, meaning did these patients have lower chance of developing distant metastases, whether in their lungs, liver, brain, etc. And again, it showed that those who received the vaccine plus pembrolizumab had an improved survival there, and it was also statistically significant. And then toxicity. So did 2 drugs actually cause more toxicity than 1 drug? Interestingly, not so much. If you look at just the serious toxicities, which we call grade 3 and higher, actually it was kind of about the same. And if anything, the 2-drug arm actually had maybe even less serious toxicities. That's probably not statistically significant. I think the point is here is that 2 is not more toxic than 1 in this particular trial. Okay, so that combination that I just spoke about is now being conducted in a phase 3 trial, of which data we don't have access to yet. But once we do, perhaps that might become a new standard in the future. So now we'll talk about advanced melanoma. So what are the current standards in advanced melanoma? So obviously, if someone has a BRAF mutation, they can get a BRAF MEK inhibitor, targeted oral therapy. But for the immunotherapy folks, the standard is a PD-1 drug by itself, or a little bit more commonly, a PD-1 drug plus a second immunotherapy drug. So it could be nivolumab and ipilimumab, you guys might have heard of, or nivolumab plus relatlimab, called Opdualag. These are kind of the standards. But what's coming down the pike? So this is these drugs are similar to nivolumab and relatlimab. So just like relatlimab, that's an anti-LAG3 antibody, this is studying fianlimab, it's just by a different company. And just like nivolumab, which is an anti-PD-1 antibody, this is studying cemiplimab. This is a phase 1/2 trial. So it's looking at safety and it's trying to understand a hint of effectiveness or efficacy. This trial was 3 cohorts. In a nutshell, these are mainly patients who were never treated with a PD-1 drug and a small group of patients who had PD-1 in the neoadjuvant setting. The primary endpoint here was looking at objective response rate. We call that ORR. Essentially, that just means meaningful tumor shrinkage. Here are the patient characteristics, again, important for us to know to understand if this is relevant to the person sitting in front of me in my office. So in the combined 3 cohorts, 98 patients, median age 68, 49% of them had a BRAF mutation. They all had metastatic disease, whether it's to unresectable lymph nodes or to organs. They had a elevated tumor marker called LDH. 20% of them had liver metastases, and 24% of them had prior adjuvant therapy with a PD-1 drug. So the objective response rate, which means some amount of tumor shrinkage, occurred in 61%, which is quite significant. And another way to show that, you guys, is on the top right. We call this a waterfall plot. So basically, every bar on here, no matter what the color, is a patient's response. And the upward deflections are people's tumors that grew. The downward deflections are people's tumors that shrunk. So this is another way of showing that objective response rate. And interestingly, in this trial, 12% had a CR, which we call a complete response, where their entire melanoma disappeared. Is this toxic? Well, it's, in terms of overall grade 3 and higher toxicities, it was 44%. And of that, 30% of them were serious. But to be honest, with our current doublet standards that we treat people with, whether ipilimumab, nivolumab, or nivolumab, relatlimab, this is not that far off, and in fact, perhaps lower than our ipilimumab, nivolumab data. So this combination of fianlimab and cemiplimab is being studied in a phase 3. And so once we have those results, this might be a new standard in the future. Next, we have relativity 048. So you guys have heard me talk about nivolumab, ipilimumab, relatlimab. You might be thinking, why not just try all of them together? And this is exactly what they did in this trial. So this is relativity 048. It was an early phase trial, phase 1-2. They looked at very specific dosing of nivolumab, relatlimab, ipilimumab. It was in a small group of patients, only 46. These patients all had to have unresectable metastatic or stage 4 melanoma. They could not have had prior treatment in that setting, but they could have had treatment in the neoadjuvant setting as long as it was at least 6 months previously. The endpoints here were safety and objective response rate, which is, again, tumor shrinkage, among some others. In a nutshell, in this 46-patient trial, median age of patients was about 61. They had excellent performance status. 87% of them had a performance status of 0, which means they had 0 effect on their day-to-day living and on their functional status. 7% had brain metastases, 30% had liver metastases. And then if you look at this top right, in terms of progression-free survival, which was one of the endpoints, you can see that patients who had no progression at 36 months tended to have no progression again at 48 months. So meaning that there was a durability of effect. If you were progression-free at 3 years, you tended to be progression-free also at 4 years. So that plateau of that curve is something we look at. We call it the tail end of the curve is a plateau, which is a great thing. It means that the therapy lasts. Because if that curve suddenly dropped within a couple weeks or months, it may not be as meaningful. Now, with this triplet therapy, the objective response rate was 59%, again shown in this waterfall plot on the right. That means more patients responded than those who didn't. Among that, 17% had a complete response, whereas all of their melanoma disappeared, and 41% had a partial response, where they had some of their melanoma disappear, but still significant amounts. How does this compare to our standard approved doublet therapies, whether it's ipilimumab, nivolumab in Checkmate 067 trial, or whether it's nivolumab and relatlimab in the Relativity 047 trial? You can see if we carefully and cautiously compare these trials against each other, which we always are told not to do, but if you take certain time points and you look at overall survival at 48 months, or progression-free survival at 36 months, you'll see consistently that the triplet did better. And then finally, it's not that much more toxic than one of our gold standards, which is ipilimumab and nivolumab. So the question is this a new standard? Not yet. I think we're working very hard to try to study this in a randomized fashion, but until we are able to do that, we're unable to offer this to our patients just yet. Okay, so next we have this IO Biotech off-the-shelf cancer vaccine. So what is this? This is first in its class. It's a dual antigen peptide vaccine. What does that mean? It basically means, as opposed to that stage 3 personalized mRNA vaccine I was telling you about, this is a little bit more generic in nature. This is targeting 2 inhibitory immunosuppressive molecules called IDO1 and PDL1. And the company basically put these 2 in a vaccine. This vaccine then is injected right into a person, and it basically teaches that person's T cells to identify this IDO1 and PDL1 that is expressed on any cell and kill it. Because both IDO1 and PDL1 decrease T cell activity. And remember, we want those T cells to remain active. So this vaccine trains a person's immune system to recognize those and kill it. So in this phase 3 randomized trial, which was actually we were quite excited about, where patients were randomized 1-to-1, 203 patients got the vaccine and pembrolizumab, and 204 patients got just pembrolizumab. And the primary endpoint was looking at progression-free survival. How many of these patients had no progression, and for what period of time? If you look at the curves, they look pretty good I'm not a statistician, but to my untrained non-statistician eye, it looks like there's a difference. So those in blue are the ones who got the vaccine plus the pembrolizumab, had a higher progression-free survival than those in red who just got pembrolizumab. But here's the kicker. When this trial was originally designed, the statistical threshold, something called a p-value that we won't really get into today, was set at 0.045. It had to meet that or be lower to have this be statistically significant. And unfortunately, the p-value here was 0.055. So because of that, it didn't meet the primary endpoint and the statistical design. So for that reason, this is not approved by any regulatory body, whether the FDA or the European equivalent, the EMA, et cetera, et cetera. So my purpose in showing this is to kind of hopefully impart to you guys the rigor with what these trials are, how they're reviewed and how they're eventually implemented or not. Okay, so you guys have probably heard of TIL. TIL is basically, it stands for tumor infiltrating lymphocytes. So what it is in a person who've had prior therapy and it has not worked, and yet they now still have multifocal disease, what has to happen is this person is taken to the operating room. In the operating room, one of their melanoma tissues is resected, or at least partially resected. It's then sent to a manufacturing facility. The patient is sent home. In the manufacturing facility, that tissue is chopped up. T cells are removed from that tissue. It's grown ex vivo, so outside the body with cytokines and basically supportive signaling molecules. And that takes some number of weeks. And those T cells grow to the billions and billions. After a number of weeks, those T cells, which is now called the TIL product, the tumor infiltrating lymphocytes, are sent back to the person's hospital. We then prep the patient for those TILs. We give them about 7 days of chemotherapy. We then give them the TIL in the hospital, and then we follow it up with a very toxic medicine called interleukin-2. So as you can imagine, even though this is FDA approved as of February 2024, this is probably not the right paradigm of treatment for everybody. It requires operation, it requires a pretty toxic medicine, it requires certain things in terms of cardiovascular and pulmonary, heart and lung status. And so the question is, can we do this in a different way? So that's what the Obsidian OBX115 TIL product is looking at. So this is an engineered TIL. What does that mean? So this is basically T cells that are engineered to express a membrane-bound interleukin-15. It's a different interleukin, not interleukin-2. But that interleukin-15 can help these T cells get activated, grow, et cetera, et cetera. The nice thing about OBX115 is that we don't have to use interleukin-2. So the way this trial is designed, this is the Agni-01 trial. By the way, Agni in some languages in India means fire. So in this Agni-01 trial, OBX115 is given after a small amount of chemotherapy, same as before, but maybe in a little bit of a lower dose. Scratch that. Before the chemotherapy is given, the tumor is actually harvested, but this time, not necessarily in an operating room. It can actually be done with a biopsy, which distinguishes it from the TIL that I just talked about. So the biopsy's done, it's sent off. They're doing their thing with growing the TILs. In the meantime, after a few weeks, we bring the patient in, we give them chemotherapy in a little bit of a lower dose compared to before. We then give them that OBX TIL infusion. And then instead of following it up with IL-2, we follow it up with an oral drug called acetazolamide. And the reason for that is acetazolamide binds to a particular drug-responsive domain on the membrane-bound IL-15. It activates it, and that's how the TIL works. So the question here is, could this maybe be accessible by more patients, because there's no operating room necessarily needed, there's no toxic IL-2 necessarily needed. The problem is, guys, it's only been studied in 11 patients. The median age is 52, which is fairly young, so it may not be perfect for many of the patients we see. 36% of them had a BRAF mutation, 100% of them had advanced disease, which was unresectable, 73% had an excellent performance status, again, might be challenging with some people we see. These patients were heavily pretreated, which is a good thing in the sense that we are testing this in the right patient population. And interestingly, many of these patients never responded to immunotherapy. We call that primary resistance. And before we talk about the effectiveness, remember, because this is a phase 1 trial, the objective of this is safety. So if you look at the first 28 days, in terms of mild, moderate, severe, depicted in yellow, orange, and bright orange, they mostly were mild to moderate in terms of side effects that occurred, and they mostly all went away after 28 days. Now, of the small number of patients that we treated, they did various doses of those TILs. So, X billion compared to Y billion. And in the dose that's going to move forward in their ultimate large phase trial, which is what we call the recommended phase 2 dosing, 67% of an objective response rate, which is kind of amazing. So we're saying these patients who are heavily treated, many of them never responded to immunotherapy in the first place, with an objective response rate of 67% is very, very meaningful. And 17% of them had a complete response. And this is just some quick, this is an MRI or CT that's showing some lymph node shrinkage in kind of the middle of the pelvis. And then on the right, you see these are just some skin lesions that have completely disappeared after a number of weeks of therapy. And finally, I feel like I cannot get off this podium without briefly mentioning RP1. So this has been in the news recently. So RP1 is a second generation TVAC that was just brought up beautifully. So this is vizolamagine Breparavac. So RP1 is an oncolytic virus, same as before, herpes simplex type 1, that you inject, same as before, with the only difference being that you don't have to just stick to skin spots. You can have your interventional radiology colleagues inject this into the liver, into the lung, into deep lymph nodes into the body. So that's what separates this from TVAC. So in this trial, the IGNITE study, which was a phase 1-2 trial, patients received RP1 plus nivolumab in a specific number of doses. And long story short, in all comers in the far left, 156 patients, the objective response rate in this previously treated cohort of patients was 32.7%, which may not sound like much, but it's kind of significant in a patient population in whom they didn't respond to anything else previously. Not only that, if you take a subset of those patients who received Ipi/Nivo, the response was 27%. And then if you look at a subset of patients who never responded to immunotherapy in the first place, the response was 34%. So here are some actual pictures. So here you have a person who had a melanoma tumor injected with RP1, and they're getting nivolumab, don't forget. And you see the injected lesion definitely gets better in 9 months. And then even the lesion in the liver that was not injected gets smaller over time. And same with lymph nodes in the middle of the chest, what we call mediastinal hilar lymph nodes, got smaller and actually may have even completely disappeared over time. We call that the abscopal effect, meaning I'm injecting here, but yet we're seeing internal shrinkage that's distant from where I'm injecting. Now, of course, it's challenging because this person's also getting nivolumab, so you don't know what's working where. But remember, all of these patients had gotten prior PD-1 before. And on the right, you see a person with a right-sided mass on their face that completely disappears in 12 months, and a non-injected right lung mass that completely shrinks in 12 months as well. So finally, the question is, all these new advances that I just chatted about, is this addressing all the needs that our patients come to us with? So what do we do when a patient doesn't respond to therapy, even doublet therapy like Ipi/Nivo or Nivo-Rela? Should be considered TIL? Should be considered a clinical trial? When do we give them BRAF/MEK therapy? All of these, I hope you guys can see, need confirmatory phase 3 trials for these to be really approved by a regulatory body such as the FDA, and for us to be able to actually offer them to our patients. And then what do we offer our patients for whom these trials are not appropriate? Patients who might be more frail, more weak. They may have an elevated tumor marker status, which is poorly prognostic. They may have brain metastases that we may be having some difficulty controlling. And ultimately, our goal is to really ensure that all of these advances that we are making, that ultimately all of our patients can try to avail these various therapies that are out there. So that is the ultimate goal. So with that, I thank you for your time.
So if anyone's, it's very timely, if anyone's ever wondering what happens at our big annual oncology meeting at the end of each May, which is always in Chicago, and I'm always jealous because Sue gets to stay in her own place and we all have to travel. We see, you basically saw what is presented. So this is the outputs of these tremendous efforts to conduct new research. This is how the data is summarized. We spend a lot of time talking about it, picking it apart. And also, I think she did a great job describing how many steps these drugs have to go through before they're actually something that we just order and do kind of as a standard of care. So I thought that was lovely. I'm sure there are a few questions, so here we go.
This seems minor in the whole scheme of things, but I'm a 3-time melanoma survivor based on just surgery. However, recently I was given a supplement from a dermatologist called HelioCare. And what I'm asking is, supplements are supplements, but is that something that you've heard about? What they say that it does is it helps with any kind of skin cancers, and I've had many of them. Probably 30 things removed from my body. And so I do have a mutation, but is a supplement going to help minimize these T cells from creating more cancers? I'm also a lung cancer survivor, so.
Gosh, well, that's a great question. I mean, I can't speak to that particular supplement as a medical oncologist. I would love for any of my colleagues to speak up if they can share. In general, I hate to be a Debbie Downer, but I usually tell my patients that these supplements haven't usually been studied in a rigorous, randomized fashion to really show that they are effective, number one. Number two, the other thing I worry about in supplements in general, not necessarily yours, is that no one is regulating them. So who knows where they're being made? Who knows what they're being made of? Like, even the capsule surrounding the supplement, like, what's in it? I have no idea. And so what I generally say is, let's try to get our nutrition through a healthy diet as much as possible. And of course, there are some supplements that might actually be beneficial. I'm just throwing out examples. Vitamin D is one of them. For some people, that is needed for their bones and their bone health. But in general, I'm a strong believer of doing things in moderation and having just a healthy diet to try to get the vitamins and nutrition we need. But I certainly can't speak to that particular supplement. I'm sorry.
We got the microphone coming in from this side there.
Very compelling to listen to. I got to give you credit for taking that content and turning it into a easy to listen to presence. So you got that. Why not any talk about what we're hearing so much now about freezing tumors and they die? I can't remember what it's called.
Like cryoablation. That's a great question. So some of my colleagues might be better poised to talk about that. So as a medical oncologist, we really focus on systemic whole body therapies, whereas cryoablation might play a role in someone who has less tumor volume. So that is generally not the type of person that I see in my clinic as a medical oncologist. Does that make sense?
Or if there's maybe just one particularly problematic spot, something like radiation or cryoablation might be a useful tool, but often not possible to do that for where there's numerous spots in the body, unfortunately.
Of course.
Hi, great talk, thank you. I'm a current immunotherapy person, and it's working. It's with the nivolumab right now. I heard they say they don't know why, but people that have been getting their COVID shots regular are doing better with immunotherapy, statistically. But I hear we don't know why, but statistically, it's good.
Yeah, that's a great question. It's apparent that you're keeping up with all the news and advances that are happening. So we were actually just talking about this last night, that there has been a paper that's shown that people who've had the COVID vaccine, that perhaps their immune system is more functional and is actually able to kill the tumor. However, one of our mutual colleagues at Sloan Kettering, in their institutional cohort, they haven't seen that same effect looking long term. So is it something that could help? I think the jury is out. I don't think that that's a reason necessarily to get the vaccine, right? But however, at least I think we can safely say that the vaccine is doing no harm to the anti-tumor immune effects that we are hoping for. But that's a great point.
One more, and then we'll go to lunch. Great, right back here.
Mine's more of a curiosity question in terms of that I failed both TVEC and immunotherapy, and then I got the big guns immunotherapy, and that put me into liver failure. So first question, is it accurate to say that because I had a reaction that I'll never be able to do immunotherapy again? Ultimately, surgery ended up being something that helped me, but the concern for me, of course, is recurrence and what would be in the future for me. And at what point in time do any of us, or would it be considered for us to get the vaccine, the melanoma, well, I'm not even sure what you're calling it, but the melanoma vaccine?
Sure, that's a great question. First of all, I'm sorry that you've had difficulty tolerating these drugs, but hopefully, I hope to assure you that that is actually not uncommon at all. I mean, a lot of our patients have quite significant toxicities to these drugs. As we've kind of alluded to, that's kind of how these drugs work. And they cause a lot of inflammation, and sometimes, frankly, these immune cells get confused. They infiltrate normal tissue, such as the liver, cause liver enzymes, and kind of a non-viral hepatitis type picture. So, in a nutshell, I can't speak to your case specifically, of course. I would defer to your oncologist. However, it's not a perfect contraindication if someone has had a toxicity. It really depends on what kind of toxicity it is. For example, I'm going to give you a very extreme form of toxicity. Someone who has an extreme Guillain-Barré syndrome, whereas their nerves start working, they almost become paralyzed. In someone like that, I would be much less prone to re-challenging them with immunotherapy if they did recur. However, with someone with hepatitis or maybe colitis, etc., I don't think it's as much of an absolute no-no. I think it has to be very per person, per case discussion, very frank with the patient in terms of what is your, risk aversity or not. Are you willing to take a risk? This is kind of this is how we would approach it, et cetera, et cetera. So it becomes a very nuanced discussion, with the doctor and the patient.
And then the vaccine?
Good question. So remember, the vaccine isn't yet approved. If it's approved, though, I think we have to think about the fact that the trial looked at the vaccine being given, forgive me, I don't want to misspeak, but it's usually within a few weeks of surgery, around 12 weeks or so. So for someone who's past that, perhaps their surgery was a year or two ago, I fear that they would not be eligible for the vaccine, but of course, ultimately, it'll be up to the FDA and how they determine the eligibility.
So do you think that it'll ever get to a point like COVID? Oh, I'm so sorry. So do you think it'll ever get to a point like COVID where we get the COVID, in essence, vaccine every year, every 6 months, or never, depending on the person, to help prevent?
Oh, that's a great question. Right now, we don't have anything like that. Like for earlier stage disease, we have, I don't know, I guess is the answer. Also, we have to think about the fact that for earlier stage disease, the likelihood of them getting melanoma is probably much lower. So is it worth it to give them a vaccine? Are we going to really meaningfully lower their risk? I think you ask a very good question, but I don't think we don't have enough data right now to think of it as being used in the preventative setting.
I think Dr. Hanson wants to say one. I'll say, to build on that, what the studies that Dr. Chandra displayed, people have been trying to do cancers and vaccines for decades, and it has been kind of strike after strike after strike. And maybe, if these results are confirmed, maybe we've finally made progress and actually have things that deliver. So I'd say the enthusiasm for cancer-related vaccines is renewed, but we still have to see the data confirmed. That's my comment. Dr. Hanson.
Just a comment briefly on the To briefly comment on the HelioCare, I agree entirely. General approach to supplements is a good diet, broad exposure. We do have actually pretty good evidence for the specific ingredient. The brand doesn't matter so much for that, but it's a fern extract. And similar to sunscreen, it gives you a little bit of protection. So if you take it daily, probably the equivalent of a SPF 3 or 5. So if it took you 5 minutes to burn, it may take 15 or 20 minutes if you take it every day. So for a little bit around the edge, it's effective, and I recommend it to a number of my patients, but it's not a major change in how your body interacts with the sun. But it's like putting on a small amount of sunscreen every day without needing to put it all over your body. So it can be helpful. I take it myself.
Well, with that, I will dismiss us all to go eat something. So thank you so much, Dr. Shain. Oh, if the folks who have spoken this morning are going to be speaking this afternoon could hang around the front, and we're going to take a photo of the speakers.
You a short presentation, just a little overall view about the MRF, and kind of show you some free resources we have for patients, caregivers, and even some providers as well. First, I just want to give a shout out and thank you to our symposium sponsors, Bristol Myers Squibb, Pfizer, Merck, Immunocore, Castle Biosciences, Iovance, Regeneron, Delcath, and Imantix. These amazing companies have sponsored not only this event today, but several of our other patient symposia events and even some of the webinars throughout the year. And we could not put on events like this without their support. So we are very grateful to them. If anyone representing these companies, if you could just raise your hand just so we can see who's here. Castle, anyone else here? I know Tim over there. Thank you. Thank you guys so much for being here today and supporting patient events. Before I give an overview about the MRF, I just wanted to share just a few facts about melanoma. I'm sure some of you probably already know these. Just to kind of know that you're not alone. In 2025, over 212,000 people living in the United States are expected to be diagnosed with melanoma. Nearly 93% of melanoma are thought to be caused by exposure to UV light and sunlight. Melanoma is not just a skin cancer. It can develop anywhere on the body: eyes, nails, feet, mouth, etc. And the 5-year survival rate for stage 1 to 2 localized melanoma is 97.6%, which is, I like to see those good positive numbers. And today there are over 1.4 million people living with melanoma in the United States. The Melanoma Research Foundation is the largest independent organization developed to melanoma, committed to supportive medical research to develop effective treatments, some that we mentioned today, and eventually a cure for melanoma. The MRF also educates patients and physicians about the prevention, diagnosis, and treatment of cutaneous melanoma and the rare subtypes, including ocular, mucosal, pediatric, and young adult and acral. How many of you guys have heard of the MRF before today? Oh, great. The MRF was founded in 1996 by Diana Ashby, who was diagnosed with melanoma, and after a 3-year battle found that there were no options, 0 options for new therapies in clinical trials. This is a picture of Diana and her husband. So as you can see, a lot has happened since 1996. Diana's legacy lives on through the MRF and all the incredible work that we do to accelerate medical research while educating and advocating for the melanoma community. The MRF consists of 3 pillars, which are education, research, and advocacy. This is considered an education event. This is what I do in my role at the MRF. I help put on events like this, as well as some other things that we'll mention real quick in this presentation. A little bit about our footprint today. The MRF hosts several events all over the country, even though we are headquartered in DC, but we travel all over the country, including we have 19 5Ks in different cities and states, 2 signature galas each year, one in New York and one in Colorado. And we bring patients and caregivers to DC to talk with congressional leaders about what is needed and why more funding is required for melanoma. We also host about 6 patient symposia like this around the country at different cancer centers, and then one focused on a rare subtype. Research is really at the heart of our mission, supporting scientists whose discoveries lead to better treatments, improve outcomes, and new hope for melanoma patients. This slide highlights some of the groundbreaking research that MRF has funded in the past and continues to support today. We have awarded 34 grants in 2025 and have funded over $28 million in research overall. The MRF has supported one research project here at Fred Hutch. It was a $100,000 Career Development Award to Dr. Joshua Veach for his work to study the treatment of melanoma using engineered T cells called CD4+. This exciting research will be published in the next 1 to 2 years, and Dr. Veach hopes it will eventually lead to a clinical trial in humans. MRF supported, helped Dr. Veach start one new scientific collaboration and secure additional grant funding from other sources to further his research, so keep an eye out for that. This is one of my favorite slides to kind of show how melanoma research can really affect so many different cancers. By funding melanoma research, you are actually also helping to advance all cancer research. Melanoma research breakthroughs have led to approvals in both targeted therapies for BRAF mutations and immunotherapy treatments for many cancers. Many of you can see here on the slide. Since the development of immunotherapy in the last 10 years, distant metastatic disease patients' survival rates have increased from 15% to over 50%. So supporting melanoma research, you are actually supporting all these cancers. Another facet of our research is our Breakthrough Consortium, which accelerates melanoma translational research through multi-institutional collaboration and fostering the growth of early career scientists and clinical investigators. So these are some of the other centers we work with around the country. We have a variety of educational opportunities, not only directed at patients, but we create educational offerings for caregivers as well, who are so important. Family members and providers. Our educational program includes, we have a ton of educational literature, webinars, animated patient videos, patient and community forum, online education courses, patient and caregiver symposia like today, information on rare subtypes, and more. The MRF has created over 30 pieces of educational literature available for free to order for clinics, schools, community events. Topics include cutaneous, ocular, mucosal, pediatric, as well as youth prevention and clinical trials. All those 30 pieces of educational literature are free to order. So if you're doing an educational event, you're looking for something, please check out our educational literature page. We also send them to cancer centers, dermatology clinics, all over the country. And so we have so many great resources. So if you're looking to help educate others and you need some free education, please check out our website. We also host monthly Ask the Expert webinars. We have 6 animated patient videos and 3 more currently in production. These videos are all less than 10 minutes long and pack in a lot of information with great visuals. So I always say if you're looking to just kind of get a lot of information in a very short period of time, these are a great resource, the animated patient videos, to kind of watch just to get a little bit of information. And if you're looking for more educational content, MRF has over 100 on-demand videos that can be found on our YouTube channel, which also includes past patient and caregiver symposia like the one today. And today's symposia will also be on our YouTube channel in a few weeks. And we also have the Ask the Expert webinars that I mentioned that we do once a month. Those are all on our YouTube channel if you're looking for anything to learn a little bit more about. We have an amazing patient and community forum. Conversations include a range of topics such as new therapies, rare subtypes, how to handle grief. The community forum offers a great place for patients and caregivers to connect with others, to seek answers to questions they may have about specific topics. So please check out our forum if you have any questions or if you want to talk to other people that are maybe going through some similar things that you're going through. I also want to introduce our new Sun Safety e-learning education program for children. It's called SunAware. We just launched it in September. SunAware is a K through 5th grade e-learning program encouraged to build healthy habits that prevent melanoma, skin cancer, and sun-related skin damage for children, which is really great. We got to get them early. This program is completely free, and we're currently conducting outreach to bring SunAware to schools and also youth organizations across the country. If you're interested in learning more about SunAware, please check it out on our website. It can be found under the Education tab. And I think it's just, a really great way to try to educate our youth, get them early, start teaching them that sun safety is really important and, how to protect their skin before they become those teenagers that want to go tanning all the time. As mentioned before, we also every year bring patients and caregivers to the Hill to meet with congressional leaders. We work with legislators and policymakers to help increase funding for cancer and specifically melanoma research. If you'd like to attend our Advocacy Day next year, please reach out to me and I can connect you to our advocacy director. This is in Washington, D.C., and it's usually around March, April. Oh, our Hill Day was March 1 through 3rd, 2026. We just had it a few weeks ago. We have several prevention and awareness campaigns, including our Get Naked campaign. I don't know if some of you have heard about it. We literally just announced our new Get Naked campaign spokesperson yesterday. I don't know if you guys know Melanoma patient, super yacht captain in Bravo below deck, down under star, Jason Chambers is our new Get Naked spokesperson. Really excited about that. So we just announced that yesterday. And then we also have a I Get Dilated campaign for ocular melanoma, Out of the Shadows campaign, which focuses on mucosal melanoma, and Spot the Dog campaign for the pediatric melanoma awareness. And as you can see, Spot the Dog is also part of our Sun Aware program too. We also have several programs that we support, that we have Dermatology Alliance Council, the MRF Breakthrough Consortium, and Mucosal Melanoma Initiative. You can find more about any of these on our website. There are many opportunities to support the work of the MRF through a variety of programs, events, and as I mentioned before, research funding, of course. If you're interested, reach out to education@melanoma.org, or feel free to come up to me and I'll give you my card to learn more about ways you can get engaged in the melanoma community while also invested in our shared mission. And the best way to learn more about everything I talked about today, the MRF, including information about our education, advocacy, and research programs, awareness campaigns, and any upcoming events we have, is to follow us on social media. I also want to say we really do appreciate your feedback. Dr. Hall mentioned this earlier. Please take a moment to complete the program survey. There's a paper version in the folder. If you didn't get a folder, there's plenty more out there. But also on the agenda, there is a QR code that you can scan and do the survey online. We really do take your feedback seriously, and it helps us improve future sessions and develop new programs. And it also lets all the speakers know how much you appreciate them and things like that. So if you can, please take a moment to do that. Again, I just want to thank our sponsors one more time. Thank you for supporting patient events like this. It really means a lot. And of course, I just want to thank Fred Hutch Center. We've had this, we've been doing this event jointly together for many, many years. It's our longest standing one. And I personally enjoy coming here every year. So thank you again to Fred Hutch and Dr. Hall, Ritu, and everyone here. Thank you.
Great, and if you haven't had a chance to stop by the MRF table, I encourage you to do so after we wrap up today and get involved. So we have two more topics this afternoon before a little reflective exercise prior to concluding. And these are really going to be a little more lifestyle focused. These are questions I get every day in clinic about what can I do and how important are lifestyle factors and what's going to happen as far as cancer. So I'm really excited to introduce Dr. Nathaniel Watson as our next speaker. He's a professor of neurology at UW-Medicine. He's a renowned expert in sleep medicine, having served as past president of the American Academy of Sleep Medicine and the American Board of Sleep Medicine. He directs the sleep clinic at Harborview and co-directs the UW-Medicine Sleep Center. And this topic of cancer and sleep was generated from your comments over the past few years, and I emailed him as the sleep leader and said, do you have anyone in your department who would come do this? He's like, I'll do it. So I'm really excited to welcome Dr. Watson today and to hear his perspective. So thank you for being here.
Thank you, Evan, for the kind introduction and for the opportunity to be here today to speak with you all about sleep. And a couple of little comments to start with. We spend a third of our life sleeping. So if it's not crucially important to human health and well-being, it's the biggest mistake in evolutionary biology, okay? The other thing is that sleep is something that happens given the right circumstances. It's not something you do. And so I always like to put that out there because sometimes, if I'm talking about the importance of sleep, people can get so wound up about trying to sleep great that it can work against sort of anticipatory anxiety working against you. So what are the 5 elements of healthy sleep? I have them outlined here, and I wanted to touch on them for everybody here. So number 1, adequate duration. What is that? For adults, we've done consensus conferences, we've looked at data. For adults, it's 7 or more hours on a regular basis. Okay, that's a general public health recommendation. Now, how much sleep do you need? Now, that's a different question. And it could be really a wide range. What I tell people is listen to your body, go to sleep when you feel tired, wake up spontaneously, do that for a few weeks, do the math, that's how much sleep you need, okay? But for adults, 7 or more hours is generally recommended. And be aware that nobody sleeps every minute that they're in bed. So if you want 7 hours of sleep, you're going to have to probably be in bed 7.5 or something like that. You have to have good quality. So that's a little harder to define. You kind of know it when you have it, but it has to be of good quality. Regularity is really important. So that is a consistent bedtimes and wake times. Weekdays, weekends, the more consistent, the better. Those are healthy sleep habits. Timing has to happen at night. And we'll get into some things, as I go through my talk. Of course, you can nap during the day. You can sleep during the day. Shift work is a thing. But we are built to sleep at night. Okay, so we want to try to do that. And then the absence of sleep disorders, or if you have any, we want them to be treated. So if we think about sleep disorders and cancer, what are the big players here? One is circadian disruption. So shift work in particular, 20% of the world of workers are shift workers. That probably has one of the strongest causal signals. Sleep apnea, we're going to touch on that in a minute, but the intermittent hypoxia. When you're not breathing at night, your oxygen levels go down. That has a tumor biology link. Chronic insomnia or short sleep, those are kind of different. I mean, short sleep is won't sleep. Chronic insomnia is can't sleep. Those are 2 different things, but anyway, they can be associated with inflammation. Then, light exposure at night is subtle and can be problematic, and then sleep fragmentation regardless of the cause of that. Okay, sleep apnea affects 1 billion people worldwide. It probably affects about 80 million Americans. 80% of people with it are undiagnosed and untreated. It's a massive public health problem, a massive unmet diagnostic and treatment need that we have in our healthcare system. Basically what it is, you can see it here, it's a collapsing airway. You lie down, your airway, you have about 20 muscles in your airway that have to maintain patency when you sleep. And some of us don't do that very well. So we get this collapsible airway, our tongue falls back in our airway, and we don't breathe effectively. What happens when that happens? Oxygen levels drop. What happens when that happens? Your brain, when it's posed the question, will you sleep or will you breathe? It's going to breathe. So it's going to wake you up. You're going to get fragmented sleep. We define this by something called the apnea-hypopnea index. And when we're doing a sleep study, we look at an apnea, 10 seconds or longer, where there's a 90% reduction in airflow. That's an apnea. Hypopnea, 10 seconds or longer, where there's a 30% reduction in airflow and there's a drop in oxygen saturation or an arousal associated with it. We add those things up, we divide by the total sleep time, we get the apnea-hypopnea index. So here's a study looking at, it's in animal models, and it was an intermittent hypoxia study. And these were mice that were injected with melanoma cells in their flank. And they were exposed to this intermittent hypoxia that I'm talking about. So every minute they had 20 seconds where they were provided with 5% oxygen, and then 40 seconds where they were provided room air. And that went on for 6 hours a day for 15 days. And what you can see here is that if you look at the tumor volume over time in days, these animals were sacrificed after the 14 days, but you can see the tumor volume in the intermittent hypoxia group was substantially higher than the normoxia group. And that's also true for tumor weight. So the intermittent hypoxia enhances tumor growth. How does that do that? It really creates angiogenesis or blood vessel growth that goes into the tumor that provides nutrients for it to grow. And then there are also nuclear factor kappa that can result in tumor cells expanding beyond what they normally would. So that and inflammatory factors are all contributing elements here. And then what about metastasis and survival? If you look here, you're looking at the lung area in millimeters squared. So as far as the metastatic area, substantially higher in the intermittent hypoxia mice, and animal survival, substantially less here in this particular model. They didn't sacrifice these animals after 14 days, so it's a slightly different experiment, but showing a similar thing. So intermittent hypoxia, increases tumor size and also metastases in these animal models. So let's talk about sleep apnea and cancer epidemiology. And one thing about epidemiology in general, it all has to be taken with a grain of salt, because confounding is a huge problem for these things. And I don't know if you all saw the story a week or two ago. It was an epidemiological study showing that fruit and vegetable consumption in younger women was associated with lung cancer. And so, some people are smiling. I mean, now and then they're saying, oh, maybe it's pesticides on the fruit and things like that. Nobody knows. But, I sent that story to my son and he's like, I knew it. I knew it all along. If we look here at sleep apnea and cancer incidence, this was done here in Seattle. We're looking at the standardized incidence ratio. So there's a large database of patients, over 34,000 individuals followed up over 5 years. And we're basically comparing those with sleep apnea to those in the general Seattle population without sleep apnea, and looking at cancer rates. And what you can appreciate is that overall there is an increased incidence of cancer in those with sleep apnea. And that's particularly true for melanoma, kidney cancers, corpus uteri, and breast cancer. So that is one study looking into this. Here's another meta-analysis where they look at, they go to the literature and try to find any study where people used objective measures of sleep apnea and then had indications of whether or not cancer occurred. And there were about 300,000 individuals here, 30,000 individuals with sleep apnea, about 70,000 without, and they found that overall, when a multi-adjusted model, you had about a 40% increased risk of cancer if you had sleep apnea in this meta-analytic study. And then here was another study looking at a massive population of 5.6 million individuals followed up for 3.3 years, looking at those with sleep apnea in a demographically and comorbidity matched cohort. Their diagnoses were based on ICD-9 codes. There were a little over 10,000 cancer cases. And interestingly here, they found that sleep apnea was not associated with cancer incidence overall, but some specific cancers were, and melanoma is one of them here. Okay. And then what about sleep apnea severity and melanoma? So you look at, sleep apnea severity is defined in two ways. The red line here is that this is the apnea-hypopnea index that I was telling you about. So the more respiratory events that you're having, and then the blue line is how much it affects your oxygen level. Because not all sleep apnea is desaturating, but a lot of it is. And you can see that as you go up in T-stage classification, not surprisingly, you're seeing also sleep apnea severity going up and the hypoxia going up as well. And then looking at the Wisconsin sleep cohort and sleep apnea or sleep disorder breathing and cancer mortality, over 1,500 individuals followed for 22 years, and they divided them into these typical categories for sleep apnea. So if you have an apnea-hypopnea index under 5, that's normal. So everybody has some breathing pauses at night. That's just a part of human physiology. Mild is 5 to 14.9, moderate 15 to 29.9, and severe is over 29.9 apnea-hypopnea index. And so here, when you split it out according to that, again, not surprisingly, you see a dose-response relationship between the severity of sleep apnea and cancer mortality up here at around 20 years. All right, so that's the sleep apnea and cancer relationship there in a nutshell. So we're going to pivot to shift work in cancer. So the International Agency for Research on Cancer report in 2007 called shift work a group 2A carcinogen. Now, 20% of workers are shift workers. This is a problem. About 10% of people with shift work will quit because they just can't take it. Another 20% have some difficulty, or another 20% or so will continue and not have too much problems, but the rest, 70%, struggle with it, but they're able to continue it. And this is, whether it's night shift, rotating shift, whether they're continuous or discontinuous, any form of shift work is considered a group 2A carcinogen. And this is in particular for breast, prostate, and colon cancer, but is also true for bladder, pancreatic cancer, and lung cancer as well. So what's going on here? Let's talk about human circadian rhythms. So we talk about sleep and circadian health. All right, so we have a circadian alerting signal in our body. Our circadian rhythm is a little over 24 hours, okay? So in order to keep us from constantly slowly rotating forward, this circadian rhythm has to be entrained. How do we entrain it? It's mostly by how we expose ourselves to light. Light is the single greatest way a human circadian rhythm gets entrained. And typically, in particular, light in the morning. Other things too, consistency of bedtime, wake time, consistent bedtime routine. When do you eat your meals? When do you first socialize with people? The rhythmicity of your life. These are called Zeitgebers, which is a German term for time giver. These are all things that tell your body what to expect next. Am I awake? Am I getting ready to go to sleep? What's going on? And there's also the two-process model for circadian rhythms. So the longer we stay awake, the greater our drive to sleep. What's happening is that ATP is the power pack in the human cell. Every time it's dephosphorylated, energy is created until you get just adenosine, which is a purine nucleoside in your brain. Buildup of that adenosine is what drives you. It's your homeostatic sleep drive. It gets high, it makes you want to sleep. Well, throughout the course of the day, you have this circadian alerting signal that I was talking about that's also building up, okay? And then what happens? Both of these things are high. It gets dark out. When it gets dark out, okay, your light is not hitting your eye, your retina. There are specialized cells in your retina called melanopsin-containing cells that then have a multisynaptic tract that go back to your pineal gland. It's all day long while it's light out, it's suppressing melatonin secretion. Once it gets dark, that suppression is released, melatonin is secreted, which then inhibits your circadian alerting signal and allows this homeostatic drive to get you to fall asleep, okay? So that's that two-process model of human circadian rhythms, and it's the way that we maintain healthy circadian rhythms is to have consistency in our life and light exposure. Shift work in cancer, there is a dose-response relationship. If you look at night shift work here on the x-axis and the adjusted odds ratio of cancer, you can see going up over time. And for every 5 years of night shift work, the risk of cancer increases by 3.2%. And then here, which shift is worse? It might well be rotating shift. So this is just looking at various cancers, whether you were on rotating shift or fixed night shift, and looking at the odds ratio of cancer. This breast is broken down into whether or not, how long your exposure was. Was it 20 years or more to shift work or less? And so it would seem to be that if you're going to be a shift worker, it's probably best to be on a fixed shift, and then your body can make some adjustments rather than continuously shifting. If we look at breast cancer rates across the world, darker is more breast cancer, essentially. And I'm going to show you something that's going to show you, indicate what one of the issues is here. What I was just talking about, light suppresses melatonin secretion. Look at the dark blue here. Look at where all the light is in the world, okay? So it's interesting. People that move from areas with lower light exposure to areas with higher light exposure, their risk of breast cancer goes up as a result of that. But people that make that move or live in these areas that are not sighted, it doesn't impact them, okay? So light pollution is a problem. And so sometimes when I see street lights or people randomly blasting lights around their house, it makes me grind my teeth a little bit. So we talked a lot about melatonin. Is there an anti-tumor action of melatonin? And there's a lot of things to suggest that the answer may well be yes. So this is estrogen enzyme and receptor modulation that it selectively can inhibit. And we know estrogen-responsive cancer of the breast is a problem. It can reduce proliferation and metastatic processes. It facilitates cellular differentiation, and we know that we want more differentiated cells or healthy cells. It can foster apoptosis, which is a way to kill or destroy defective cells. We heard earlier today about telomerase, and so it can inhibit, it's an anti-telomerase functionality, and we heard about that might be positive earlier today. The angiogenesis, it can reduce that. And I already told you with that animal model with the mice that's problematic. It can foster a healthy immune system, and it can interact and suppress oxidating agents. So there's a lot to suggest that it would. I'll just go ahead and cut to it right now, though. There's no really good randomized placebo-controlled clinical trial showing that melatonin, can treat cancer, prevent cancer, anything like that. There's some that suggest maybe, it improves tolerability of treatments. And there's a little bit of data there, but not a strong amount of data suggesting that there's melatonin is a cancer treatment. So I don't want anyone to walk away from this talk thinking that. Sleep and cancer survival. So of course, this is going to be bidirectional. You get cancer, you have a challenging prognosis or a poor treatment response. Of course, there's going to be some anxiety, discomfort. You're going to have side effects from the treatment. Depression might come into the picture. That's going to compromise sleep, which then in turn could potentially, for the reasons mentioned, accelerate or increase or worsen the cancer. So, not surprising, up to 87% of cancer patients report some sleep problems. About 2/3 will have some insomnia. And so, what we need to be doing, I think, as a medical field is just asking these questions of our patients so that we can optimize sleep in people with cancer diagnoses in order to make sure everybody has all those 5 elements of healthy sleep, which the bottom one is if you have a sleep disorder, we need to get that treated. And then if you look at the interconnection of sleep and cancer over time, disturbed sleep could be a contributing factor, like in somebody walking the path to a cancer diagnosis. In theory, that's what some of that epidemiology suggests. But we haven't really shown that if you optimize sleep, you reduce cancer incidence or you can improve necessarily treatment outcomes. So we're a little light in that data right now in the sleep medicine community. But you might imagine that sleep problems could contribute to the initiation of the cancer, promote its progression and metastases. So there's a role all along here to figure out ways to optimize sleep in order to optimize treatment outcomes. So, the mechanisms for an effective sleep on cancer survival, you have the chronic sleep disruption that could contribute to this pro-inflammatory signaling, which could increase tumor growth and invasiveness. You have sleep loss, contributing to reactive oxygen species and causes oxidative DNA damage. And then, it can reduce the body's ability to mount an appropriate immune response. So I hope today in my brief talk, and we'll have an opportunity to ask some questions that, we went over the 5 elements of healthy sleep. We talked about the relationship between sleep apnea and cancer and how sleep apnea is everywhere. And most people are undiagnosed and untreated. And then, spent some time talking about the shift work problem and then getting into melatonin a little bit. But with that, I thank you very much for your attention.
All right. Any questions? I have one, and then we'll work the mic over here. So it always has struck me, meeting patients oftentimes who are right around the time of a diagnosis, which I consider to be really a trauma, that it would be kind of weird if sleep didn't momentarily change at the beginning. It seems like a normal response to the trauma. When, from a sleep perspective, is that acceptable, but for how long? And when does this become something that is more of a disorder or a problem rather than a response?
Yeah, I mean, chronic insomnia is not diagnosed until you have insomnia at least 3 nights a week for at least 3 months. And that's going to affect a lifetime incidence of about 10%. So intermittent insomnia or related to a disturbing or problematic event in your life is less than that. It's quite common. It affects about 30% of people at some point as well. So I think some sleep disturbance would be expected in that situation and can be accepted. The impact of sleep on all of these things is really a long-term relationship. So having a bad night of sleep here and there is not a big deal. That's another important thing, so we're talking about the long game here as far as sleep health is concerned. Yeah.
The good news for me is I was just cured of sleep apnea after many years, beginning with a uvuloplastoplasty that I was told would cure me of sleep apnea, only to find out 10 years later that my sleep studies were exactly the same. And so I was on CPAP for 10 years, just recently getting off of it. It's amazing what 60 pounds of weight loss will do for you. But I am curious, those that are being treated with CPAP, what do you see? Is that eliminating the risk? Or is it overcoming the risk? Or those people that are in between being diagnosed? Because sleep studies are not being done as often as they really should be.
Yeah. So what we've proven in sleep medicine, if you treat sleep apnea, we've proven we can reduce daytime sleepiness, we can improve sleep quality of life, and have modest effects on blood pressure or hypertension. We haven't yet really proven that we can reduce secondary prevention of stroke or myocardial infarctions, heart disease or cancer or anything else. So the jury's still out on that. But, the data that I showed you would seem to suggest that it would have an effect. And honestly, at this point, who's going to do a randomized controlled trial of PAP on people to assess whether or not they develop cancer or if the cancer gets worse? Nobody, because we know how well PAP works at this point. Nobody that comes to see me is ever excited about wearing a PAP machine the first time I meet them, But I have tons of people that come back, oh my gosh, I would never sleep without this, and this has changed my life and everything. We've had a lot of developments in sleep research, so we have a lot of other treatments. Now, you mentioned uvulopalatopharyngoplasty, so that's a part of a suite of traditional sleep surgeries that can be done with varying levels of effectiveness. Zepbound, one of the GLP-1 medications, tirzepatide, has been FDA approved to treat sleep apnea, and we know that every 1% drop in weight reduces sleep apnea by about 3%. So that's basically its treatment effect is through weight loss. You have the Inspire implantable hypoglossal nerve stimulator, which you guys might have seen ads for. It's a little power pack below the skin. A wire goes up under your skin to wrap around your 12th cranial nerve, and it flexes your tongue muscle at a specific moment in your respiratory cycle throughout the night to keep your airway open. So that's out there. And then there's a company called ApneaMed that's developing, they're just finishing phase 3 clinical trials, developing a medication to treat sleep apnea, believe it or not. And that's a medication that increases muscle tone in the throat and has some modest effects. It improves oxygenation actually quite well. So you all may be seeing some ads in the next year or so, oh my gosh, the massive breakthrough pill to treat sleep apnea. I mean, it is a breakthrough in many ways. And then there's some fringy stuff out there as well, but that's really, oral appliances, mandibular advancement devices that move your lower jaw forward. That's another pretty effective treatment that you can do for sleep apnea. So that's kind of the options we have.
Any other questions? Oh, one in the back. Yep.
So your whole thing was about the lack of sleep and how that affects cancer. What about people like me who could sleep all day? What is the opposite? Am I reducing my likelihood of getting cancer even more times than I already have? Or like what is this?
Great question. Love the question, because you all see things all the time like that there's this U-shaped relationship between sleep and health. You can get too little or you can get too much. I don't buy the too much part. So you're okay. I mean, except, of course, if you're sleeping excessively and you're not feeling well, then we have diseases like narcolepsy and idiopathic hypersomnia and sleep deprivation and things like that could be at play. But if you look at all the research, there's tons of research in animal models and human research showing that if you shorten sleep to like 5 hours a night, that you have untoward effects on human metabolism and cardiovascular risk and mental health and immune function and over and over and over again. And the epidemiology is solid there too. There's almost no studies where people bring people into a lab and say, sleep as much as you want, and then measure all these things. But the ones that have been done don't show any problems with it. So, once you're sleep saturated, you can't keep sleeping. That's another thing. A lot of times people with insomnia will come in and see me and like, Doc, I'm awake 2 hours a night. And I'm like, how long are you in bed? 10 hours. And I'm like, well, of course, you're building the insomnia into your night, So anyway, this U-shaped relationship it's all, the long sleep relationship, in my opinion, is that a lot of these studies are looking at self-reported sleep. And so I think it's really a measure of sedentary lifestyle. And so people are reporting that they're sleeping, but they're not. And so really it's a surrogate measure of poor health, if you will. And so it's confounded by that. So if you say, sleeping 10 hours a night can be associated with heart disease, and you're like, well, no, heart disease causes you to live a sedentary lifestyle. It's going to make you overestimate how long you're sleeping. This is just my thinking around this, just so it's not necessarily been proven per se. But anyway, great question. Thank you.
I just have a comfy bed, that's all.
One more question. Oh.
Is there such a thing as healthy snoring?
Wow, I love that.
For the online audience, the question was, is there such a thing as healthy snoring?
No. But I did have to think about it. I would look at it this way. Sleep disorder, breathing, or sleep apnea happens on a continuum. Snoring's at the lowest level of it. But there is research showing that snoring is associated with increased intima media thickness in your carotid arteries, and that's a risk factor for embolic stroke. So the vibrations of snoring itself, if it's just that, can cause vascular damage that could be problematic. So, all right, thank you all so much.
Thank you. All right, excellent questions. And I did see one online that just came up, and we'll try to get you an answer to that after the symposium. All right, for our last of the formal talks, we're staying on the topic of lifestyle. So it's really exciting to me to introduce Dr. Dongwoo Kang, who is an assistant professor at Fred Hutch in our Epidemiology and Public Health Sciences division. Since the last time we talked about exercise at this meeting, he has actually been recruited, and we brought him here, and we're really excited about that. And I'll try to explain why, and you'll hear why. He's a PhD in behavioral medicine from the University of Alberta, and then did a postdoctoral fellowship at Dana-Farber Cancer Institute and Harvard Medical School. He is, to my knowledge, the only clinical exercise physiologist with his skill set who's been employed as a researcher at our cancer center. And his research investigates the role of exercise in cancer treatment and outcomes. His work looks at an exercise as medicine approach to understand how exercise might help cancer treatments work better and reduce the side effects of treatment. He has developed and been involved in numerous trials looking at elements of exercise, diet, and immunotherapy efficacy in cancers like melanoma, lung cancer, and prostate cancer, including a trial he has opened here at Fred Hutch that is currently enrolling melanoma patients on immunotherapy. So if you want to ask him more about that after the session, I'll tee you up. So anyway, I think you'll enjoy this talk quite a bit. Dr. Kang, welcome and thank you for being here.
Thank you. Thank you so much, Dr. Hall, for the kind introduction. It's very good to see you all this year. As Dr. Hall mentioned, that I am very, very excited to be here and very honored to speak about exercise. As you might know, exercise is good. What can I talk, right? But there must be something that I can give you some more information about. So today, I want to start with some of the slides or the keyword that I really like before we start. Okay, I'll just use this. Sorry.
Maybe this.
Oh, yeah.
There we go. There you go, yeah.
Thank you. So, 2,000 years ago, Hippocrates, who is the father of medicine, he wrote this way: if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to health. This is a very strong keyword, even 2,000 years ago and over time, that we are finding that this is actually really true by science. So I know this is something that we already know, that eating well and being healthy, being more active is healthier. But I think it's really good to know that this has been around in human, and that we want to focus on the diet and exercise, and I want to talk more about why it is more. So there are 3 parts for my talk today. I want to talk about what's the current evidence on exercise and melanoma specifically. I could talk about exercise and cancer in general, but I want to focus on melanoma today. And then secondly, does exercise help with my immune function, and how does it help with what exercise does with your immunity? And then I'm going to give you some exercise informations for you and for you to participate. Okay, why are we even talking about exercise? For a long time, we also when we talk about exercise in the clinic, we were told that, oh, why don't you take a rest? You just got cancer treatment, you're so fatigued. Over the time, there have been, mostly last 20 years, over 1,000 exercise clinical trials that are investigating how exercise can help with cancer patients. And then, all in all, the idea is the more you we are physically active, the healthier you can become. So the idea shift over the last 20 to 30 years has been really groundbreaking in our field, because I want to give this example. When 50, 60 years ago, when a cardiac patient comes into the clinic, the first thing they do after the cardiac surgery was being rested for 8 weeks in the bed. Right now, if you get a cardiac surgery, the first thing you do right after the surgery is exercise. So the direction, the changes that they're making with the exercise can be very different. So with the cancer, we are developing some evidences, but I think we are not there yet like cardiac health, but we are getting to that similar direction, that how exercise can be important for cancer patients. However, only 15 or 25% of patients are meeting, we call it meeting the exercise guidelines that we recommend to patients. So more than or 75% patients are not actually physically active enough. So this is a big problem we want to solve. We all can together think about it, and we can resolve this. And with more than 1,000 exercise studies that we have put together a guideline or put together the evidence. So I'm just showing this because this is highest levels of evidence on what outcomes can exercise can help. So these outcomes, including fatigue and psychological health, including quality of life, anxiety, depression, and physical function and lymphedema, mostly for breast cancer, and then bone health. These are having quite a substantial evidences. I want to talk a little bit more about the fatigue because fatigue is one of the biggest limitations why patients mostly who are receiving treatments are not doing exercise. But it's relatively very counterintuitive. If you think about exercise, I'm so tired, you don't want to go out and do exercise. And then you get into the cycle that you're not doing or improving your energy, or that's needed to be more active, more healthier and be active. So you're getting into this vicious cycle. But when you get tired, you're fatigued, if you do exercise, there is a large study that are comparing exercise and this fatigue medicine and other lifestyle intervention. Exercise, physical activity has the biggest effect on improving fatigue out of any other medications and lifestyle interventions. So if you can think about fatigue, if you're not feeling like doing exercise, that's when you need to do exercise. This is very counterintuitive, but when you're feeling fatigued, exercise can be really helpful to improve or can be better with the fatigue. So I want to talk a little bit more about other than these outcomes, there are some other emerging outcomes that why exercise can help with the melanoma patients. So when we look at the large patient cohort data, does physical activity actually reduce the melanoma risks? So when we put together all the cancers, let's say most common 17 cancers, we call our physical activity is reducing cancer risks about 30 to 40%. But melanoma is one of the few cancers that are actually increasing the risk of incidence, about 27% in this particular meta-analysis. We just put together a lot of core studies. But when you look at the details, this analysis is not accounting for UV radiation exposure. So when they put that factor into that analysis that this is affecting the risks, then melanoma risk is actually reduced. But it's just not statistically significant in that particular study. But the direction that's going when we are accounting for the UV radiation, it's extremely opposite. So in this slide, I want to just highlight that, like the sun aware that we just saw. When you go out for physical activity, put the sunscreen. This is really important, and I can't highlight enough because now sun is out there, and it's really nice that you want to go out. And this is really important for reducing the risk of melanoma when you're doing a physical activity outside. And we are doing something also very important with the melanoma tumor and exercise. So this is some animal studies. I think it's really, really provoking for most of us because when I'm looking at this, when left top slide, they are comparing this one group of mice were sedentary and the other group of mice was doing exercise. We call it mostly like moderate intensity exercise. In the cage, we put a voluntary wheel so they can exercise as much as they can. So they probably run about, like for 1 week, they can run about 1 kilometer or something. They do a lot of physical activity. Then when you look at that, this is a tumor volume. So compared to the sedentary mice, exercise, the tumor in the exercise group reduced about 70%. And this has been repeated in many other animal studies. This is one particular study. And then when we also look at we took out their lungs after the exercise, the 8 weeks of interventions. And this is what they took, the photos of their lungs, and the metastasis in the lungs is really different, which is more than 80% of the reductions in the metastasis in the lung in the exercise. And then this is really also fascinating because this study is another study that have had these mice in the water and had them swim. So they compared two groups this time. This left is just sedentary mice and then exercise mice. They actually compared low dose exercise and high dose exercise. So this low dose exercise means they did about 60 minutes of swimming a day. And then moderate dose is about 20 minutes of swimming a day. So we can see their tumor sizes over time, how much they have decreased. And then we can see there's a little bit of more effect or a greater effect of higher dose exercise on tumor cells. It's particularly melanoma tumor cells. So what we are seeing here is the more the exercise is good for reducing tumor sizes in these animal studies. And also if you do more exercise, it seems that exercise, there's tumor size, there's a better benefit in reducing tumor cells, tumor sizes. And what does that mean then? Like what's the low dose exercise for me? Like what's high dose exercise? I can give you a little bit of context. The low dose exercise, very basically, 1 day for mice is about 40, 50 days for human. So, and then there's metabolic rates, and then there's relative time scaling differences. When we put all things together, so low dose exercise is about 15, 20 minutes of moderate to vigorous exercise. And then moderate dose exercise is about 30 minutes to 40 minutes of exercise. I have to put it that way for a human. So what they did is not extremely difficult. That's what I want to say. How about treatment then? So this same study did a very, very interesting experiment too. So at this time, they did the same, just one exercise group, and then my group of mice, they were receiving immunotherapy only. And another group had immunotherapy and exercise together. So you can see there's a bigger effect of immunotherapy or treatment effect on their tumor in the group of mice who did exercise together with immunotherapy. And then when they look at the tumor cells inside, looks like there's some more, there's a brighter side is particularly T cells, one of the adaptive immune cells in our body. There's the more activated immune cells in the tumor cell in the group of mice who are exercising with immunotherapy. And then Dr. Watson just mentioned about hypoxia is one of the hallmarks of cancer. And exercise actually improved oxygen delivery or reduced hypoxia within the tumor. These are the two main mechanisms that we found in this type of study. This is very, very provoking. And also, similarly, what Dr. Watson said, so this is the animal studies. We haven't done any particular clinical trials or large trials that can say, oh, exercise is actually reducing your tumor cells or reducing your metastasis. We do not have evidence in human settings. But this is where we are. We are trying to do more researches on that. It's my interest that I'm trying to translate these evidence into patients and see it's actually working for patients as well. And then I want to kind of go through about the exercise and what happens in your immune system really briefly. There are a number of immune cells in our bloodstream. And then once you do exercise, these are moving around and can help with your whole body system. And what I wanted to say here is our body is creating mutations which can lead to tumors or carcinogenesis in your body, but your immune cells are finding those cells and killing them every day. It's happening right now in our body. So it's like consistent cancer growing and then cancer surveillance and killing. And exercise is systematic changes in your body, the physiological changes. So when you do exercise, one of the things that are happening with the single exercise, when you're doing exercise right now, exercise increases your heart rate, right? If you don't, it's a problem. It increases your heart rate. And then your body, in your bloodstream, there's a faster and stronger blood flow in your body. And you think about these immune cells are not just moving around all the time. If you don't do exercise enough, or if you're sedentary, or if you're just body's not moving around a lot, there's greater chance that the immune cells are not mobilized in your body. So when you have a greater blood flow in your body, these immune cells are kind of stuck somewhere in your body, and then this stronger blood flow can scrape out those immune cells and come into the blood flow, can help this cancer or immune surveillance in your body. And then these immune cells can be 4 times higher available in your body, can help increase your immune function during the exercise. And another mechanism is due to contracting muscles. When you do running or squatting or anything, exercise, and their muscles are contracting, right? So they're releasing, when you're doing exercise, they're releasing some of the proteins. Some proteins are coming out of the muscles. And then they are helping find those cancer cells and then bring those immune cells and then come in, and then they can put it in the tumor cells to fight against cancers. So there are some of the mechanisms we found over time in the clinical models that why then, when we just saw this slide, that we are kind of explaining why, we're understanding why it's happening. And then I just talked about the one exercise session. What about if you did like repeated exercises when you train it? I just mentioned the immune cells are more available, but if you do exercise every day, they're not going to increase indefinitely. So when you're doing exercise, it increases, but over time, the number of immune cells are not really increasing in your body a lot. But what we saw is that the function of the immune cells are actually better. For example, there are old immune cells. There are strong immune cells. There are weaker immune cells. They're old and they're younger. Many immune cells old cells are dying, and then younger immune cells are newly made because total capacity is limited. But the old cells are dying, and there's a new, fresh, and healthier immune cells are coming in your body better. And then there's a lot of hormones releasing in your body when you're doing exercises. One of the key changes, what's happening is inflammation is over time reducing with the trained person, and also your metabolism, glucose levels, insulin levels are more regulated. It's obviously, you may know a lot about this topic. So that can all help reducing cancer progressions. And when I talk about the immune cells, immune function, and then when we talk about immunity, there's a growing evidence that your gut microbiome is also really related to your immune function. Some of you may have nodding, and some of you may have heard about it. And there's a recent studies that are showing that exercise is actually enhances some of the immune cells' anti-tumor immunity, and then it actually promotes immunotherapy effects in some animal models. And then there's another study that is showing that dietary fiber, if you eating more dietary fiber, that actually improves immunotherapy responses through improving your gut microbiome health. So these are more from the very preliminary pilot animal studies or preliminary human studies. And it seems like lifestyle interventions may have a higher potential to improve immune function immunotherapy. This is one study that I'm running right now that Dr. Hall mentioned, that we call it dual study that I've been running for those who are receiving immunotherapy with melanoma. We are randomizing the patients who either exercise group or diet group, or both exercise and diet, or attention control group. And then we are kind of comparing the effects of their immune function, immunotherapy toxicities, their adverse events, and then hopefully you can see their psychological health and physical health as well. So we are recruiting 40 patients, and we collect stool and blood samples, and we have physical fitness and functioning tests, and then body composition and quality of life and symptoms. And then we are randomizing the patients, and then we are providing 8 weeks of intervention. We are assessing these outcomes again and see the differences between the groups. This is what the randomized control trial we're doing right now. So I put some flyers on the desk outside. If you're interested, you can take a look, and then you can email us, or our staff can answer if you have any questions and if you want to participate. But all in all, I wanted to say that this type of research that we are doing is one of the pilot studies. But moving forward, I'm trying to do more of these type of exercise or diet studies that can help cancer patients receiving immunotherapy. And I want to mention also about the exercise and dietary. We are not giving you food if you're doing the diet. We're giving some consultations. And for exercise, though, we are actually giving you a bike. You can do it at home. You don't have to come. So you're one-on-one getting personalized training on Zoom or a virtual setting. So you're actually given some tools to the exercise. So there's some perks coming with it. So getting back to the slide I showed you earlier, there are some high-level evidence based effects of exercise, but I just mentioned some of those. But there are other universal benefits of exercise you may think of, because I don't need to sometimes highlight it, because you already know what exercise can do for you, right? There's muscle mass if you do muscle exercises. If you want to reduce fat mass, there's some benefits of exercise, reducing fat mass, also physical function, frailty, cognitive function, metabolic dysregulations, cardiovascular risks. But some of those outcomes that I'm more focused on, if exercise can help with treatment efficacy and side effects and cancer progressions eventually, and metastasis. And eventually exercise can help you live longer with a healthier body. There's some few slides left about what exercise you have to do. This is a guideline that are published by American Cancer Society and American College of Sports Medicine. It's about 150 minutes per week that we recommend you to do this minimum amount of exercise. So it's about 30 minutes a day, 5 days a week, or if you're doing vigorous exercise, 75 minutes per week, or we can put together and moderate to exercise together. This is a minimum, and then at least 2 days of major muscle group exercise, strengthening exercise. That's what's recommended at the moment. And I just want to highlight some of the tips. So you have to always consult with the doctor and exercise specialist if possible. I'm going to give you some information so you find exercise specialists as well. And generally, there's a dose-response relationship. If you're already doing some exercises, the better is the concept, and that's what we found from most of our studies. And then you can assess yourself and then set your own goal. If you're not doing any exercise right now, I'm gonna do 15 minutes of exercise from today. That's probably not feasible. If you wanna start right now, then just try to do 10 minutes a day, and then you can increase over time. And then, yeah, so these are, if you're not active, just avoid inactivity. If you're already doing exercise, just do more exercises. And then, so when we talk about the health, we could talk about exercise, but just don't forget to start slow. And then if you feel dizzy and chest pain and you're too tired, always stop. And then if you want to start today, just pick one of your favorite exercise or sports rather than, I have to do something. Don't feel overwhelmed to, do something else, but something that you haven't liked before. Or you can just start with one short exercise. Even sometimes 1 minute of exercise is better than none. If you just can't do anything, sometimes I just cooking. You cook. You're spending time for a good amount of time in the kitchen. When you're cooking, just waiting, just do some squats, like 7 or 8 squats. That's actually good, like kind of exercise we call it. So we could kind of taking snacks of exercise sometimes. And then there's a good journal and applications you can use. You can track. Watch is really good, as you know. And then many people, the most common barrier is no time. But try exercise snacking, as I mentioned. And then if you're too tired, as I mentioned, the fatigue is actually something exercise can help. And if you're not motivated, you can find a buddy and community or trainer. And this is my last 2 slides about exercise resources. The Live Strong is from YMCA. You might have heard about it. They have about, I think, 50 sites in Washington state. And then most of them have a Live Strong program, which is 12 weeks of free exercise programs for any cancer patient. Now they have Cancer Fit website. They have thousands of exercise videos on YouTube channel. So you'll be, and then there's another Team Survivor Northwest. It's another group that you can look it up. They provide free exercise for cancer patients. And then there's another exercise directory. You can look up your location on the left side in this website. This is what we have put together, and then we kind of locate all those exercise programs for cancer patients. So these resources you'll be receiving an email after today's symposium. Thanks for sending that. So she's going to send you the information to you after. So all in all, exercise is essential for most of you. And then we are approaching exercise as a medicine, not anymore supportive. Exercise may be good, but this is becoming an essential part of your cancer care. So move more today, and then use the resources you'll be receiving the next few days. And yeah, I'll take any questions. Thank you.
Thank you for a wonderful presentation. And I can't tell, I think you may appreciate how hard it is to do a study like the study Dr. Kang is doing. You're giving out many, many exercise bikes to people. That takes a lot of money. He's been very successful at getting funding to do these. So I'd really encourage anyone who's interested at all to learn more about it. We're really happy to be able to offer research around this here. I think in clinic for the first few years I was here, I was like, eat healthy and move, but there wasn't really a chance to do more than that or help contribute to things moving forward. And so really thrilled that Dr. Kang is here and going to help us move along, build evidence, and there may be some point in time where we actually write a prescription for exercise, just like we prescribe medicine in our clinic, because we have data that supports it's that important. So thanks again. Any questions for Dr. Kang?
Thank you.
I want to give a shout out to my late German Shepherd, Shani. My husband had an 11-year melanoma journey, and if you have a German Shepherd, you walk every day. And get a dog.
Yeah, I can't agree more. Too.
Especially one like a Shepherd, because you have to walk them.
Or border collie, or yeah, border collie.
All right, one more. We'll do a question in the middle there, and then we'll move on to the last part of today's session.
I had metastatic melanoma 4 years ago, and it was a complete resolution. But in the last 4 years, I've been bedeviled by some severe side effects, specifically colitis and adrenal fatigue. And I know that as a result of those effects, my desire to exercise, my ability to exercise has been hampered. So I'm just wondering how to approach the issue of exercise when your body just feels like it can't get off the ground because of severe side effects. Do you follow the same advice that you were offering? Just go out and do it, even though the rest of your body is screaming, no, 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 I don't want to do it. I'm just wondering, in that particular situation, what you might say, if somebody like me is suffering from effects like those.
That's a really good question. I think thinking about when I mentioned about when you don't want to do exercise, I was more talking about the fatigue levels when you're not having energies. When you're having more side effects that are specific to your colitis or dermatitis, there's some things that are more medical related. And then we have to listen to our body. When you have a flu or you're not feeling really well, in terms of your body is not just fatigue, it's about actually your body's responding to something, like colitis is one of them. And then it's relatively better to listen to your body sometimes if it's not just you're not low energy. So I want to kind of differentiate that. If you have something like colitis and you don't really feel like doing it, then you might be more careful that you don't want to overexert yourself to do the exercise. Then if you also want to talk to your doctor to talk about the specifics about your symptoms, instead of not encouraging you to do exercise when you're actually feeling unwell with the specific symptoms like colitis or that are relevant to more like medical side effects. Does that make sense? Yeah.
Yeah, and I would say among survivors, for those that were here last year when we talked about chronic side effects, I think musculoskeletal side effects from melanoma immunotherapy are common. And pretty much everything Dr. Kang has prescribed is moving. And moving when you're having joint pain, joint aches, muscle pain, muscle aches is hard. So even if it's not rising to the level of being severely disabling, if you're experiencing symptoms that are a barrier to you moving, especially as you move into a post-treatment phase or where the melanoma is responding, that's a great time to talk to your medical team and say, I want to do this, but my body's not letting me. What can we do to help me move better? And there's some growing research about that. So that's a great point. Awesome. Thank you, Dr. Kang. Okay, so we're now going to do the last part, and we're going to do a slight variation on the session we've traditionally called patient stories. So Dr. Bird, if you were watching this, might say, what is he doing? Why would we mess with the best part of the symposium, which it is. But what struck me this year is that we hear one amazing story, or sometimes two per year, but everyone in this room has a strong story and a reason to be here. And maybe you're not we don't have time for everybody to talk, but maybe you're not someone who's super comfortable expressing that. But reflecting on your story has a lot of value. So we've done this in medical training, what's called narrative medicine, where we try to protect some time to do some deep reflection and writing about experiences we have during medical training. And so I thought we could try an exercise where I think if you don't have a paper and a pen, raise your hand and we'll get you one. And we'll have 10 minutes of just protected time to reflect. I put up a couple potential prompts that you could use as inspiration, but the message is if your pen wants to move, don't stop it. So if what you want to write about doesn't fit one of these three, that's fine. Write about whatever your body's feeling like writing about today. And then at the end, if anyone would like to share something they've written, or a part or a sentence or a paragraph of what they've written, we'll have a few minutes, 5 or 10 minutes to do that before I wrap up. So we're going to do this for about 10 minutes. We'll see how it goes. And then I hope everyone, and also if nothing's flowing, don't worry about it. It should be low stress. But I think a chance to be a bit introspective as we come to the end of today. And and then for those that are interested in sharing something with the group of what they wrote, there'll be a little time to do that. So if we can help you with any of the implements, just raise your hand and we'll get you a pen and a piece of paper. We'll have about one more minute to wrap up whatever you're thinking about. I see some pens still moving. Certainly continue writing after the symposium. But we'll do about one more minute and then we'll have an opportunity for anyone who wants to share some of what they wrote. That's welcome, but certainly not required. All right. So thank you for trying something a little different. And if writing flowed smoothly, great. And if it didn't or it wasn't feeling right, that's okay. Thank you for reflecting for a little bit of time after such an information-rich and exciting program. Would anyone care to share anything that they wrote?
Well, I've never had cancer, but I was my husband's caregiver for 11 years, but actually he was my caregiver. Our grandchildren were young when my husband died, and I asked them what they remembered about Pa. And our youngest, who turned 6 3 weeks after Michael died, said, Pa always smiled. About broke my heart, but it was true. He was the most positive person. He was this can-do person. And I still have, he would write me notes, loving notes. I still have them. And I have the whiteboard that he wrote on all those years ago. And he wrote, and this is a quote, "Cancer is a thing. I don't worry about a thing." And we focused on our future. We didn't let it consume us, but it was because of him and that positivity. And I tell people, God is my strength. Michael is my inspiration. And surround yourself with love. And caregivers, you need to have somebody that you can dump on, all right? And I mean that, you know, because you have to do that. And mine happened to be my daughter-in-law, because I knew I couldn't really do it to our kids. So stay positive. And the advancements are incredible from the time that Michael first, and his was late stage in 2012. And just stay positive.
Thank you for sharing that. To the back, and then, also, so we'll go to the back and then down here to the front.
Okay, I'm a talker, so I promise this will be the last time I talk. So I was diagnosed with stage 3 melanoma in July of 2024. I came on my way home from work. I got a call from my ENT who had just gotten the biopsy results. And I work in a prison, and I've worked in a prison for about 10 years. So coming home from work in a prison, the last thing you want to hear is you have cancer. So I pulled over, and after not drinking for about 2 years, I decided to drink 2 bottles of wine in my front yard because I had cancer now. So I was like, fuck it. Oh, sorry. We're on the TV. Screw it. So, you know what? Whatever. This is me. Get over it. Okay. So I wanted to stay on topic and answer the questions because I could talk all day because I'm a therapist. So reflecting on the strengths that I have, I've realized over the last 2 years, because my cancer is back again, I've realized that my spirituality is the one grounding thing for me. Whether you're religious, spiritual, nothing, it doesn't matter because we're all flesh people on this rotating rock. So I think knowing that our time is not up until it's up is one of the things that I've had to keep telling myself. I am not in charge of the day that I leave. I am funny as hell, actually, okay? So I cry a lot, actually, this time around. But my humor is something that I bring into every session, every appointment, every telehealth. I cried for an hour with Dr. Hall last Monday. I'm only 30, I turned 36 in August, so this isn't supposed to happen. You know, so therapists need therapists, so my therapist is awesome. My menacing optimism, I wrote that down because it's annoying. It annoys people. The first time I had cancer, I think I cried for 1 day out of the whole time, and it was just the day that I got cancer, or was told. And And I beat it. I beat the shit out of it. So now it's back, and we're going to do it again. What has cancer taught me about myself? Going on the same train of speech that I'm a fucking badass. And again, therapists need therapists, and if you need someone to dump on, please do it to a therapist so they get paid for it. No offense, because the daughter-in-law, that's what her job is. Coming to terms with mortality. I can't speak for everybody, but being this young, even though I'm an old soul, that was not fun. Knowing that people are still living their lives worried about, gas prices, and there's more important things in life than, that, or if your neighbor's mowing their lawn and something spits out on yours. There's just too much other thing, too many things in life that are more important than those things. It has also helped me to heal things in my life that had nothing to do with cancer. Some family stuff and friend stuff, so that's been really positive to be taught. And if I was going to say something to a friend going through this, as much as it sounds positive, the most irritating thing to me is when people say, prayers and positivity will heal everything. I believe in that. I manifest things. But I think it's more important to say you're not alone. That's why I came here today. I live by myself with my 2 dogs, so they can only handle so much of this talk. I would also tell them to listen to their body and listen to the doctors and be patient, but most importantly, to advocate for themselves. But that's all. I think this therapist is done. Thank you.
The strengths that have helped me during my cancer diagnosis are the continued support and care of my medical team at Seattle Cancer Association, the encouragement of my family, and the love of my church family. I try to smile and laugh every day. Cancer made me aware of the patience and calmness that I wasn't aware of before melanoma diagnosis that has helped me cope day to day through the past 5 or 6 years. I know I can continue these traits as I go through more treatments ahead. I have a positive attitude. I will live longer to enjoy my family and grandchildren. I would tell my friends to believe in the knowledge of their medical team, follow their directions for carrying out advice at home, stay calm and grateful for positive friends and family. Count your blessings each day, attend free seminars for knowledge and inspiration, and take one day at a time.
That might be it. Oh, we got one more. All right. It's hard.
Inspired by all the I've been inspired by all the people who shared their stories over the years. There are lots of great family stories, and we always end with a good laugh here. And I just think it's such a joyful day, and I thank Fred Hutch for organizing the day for us.
Well, that feels. Would you like to share something too? Mine's short. Okay, go for it. You will be our final word.
And I Jesus.
No pressure.
I'm not going to share all 3 of mine, but something Dr. Berg told me when I was re-diagnosed a couple of years ago was, gosh, I didn't think this was going to happen. With at the time metastatic stage 3, now I have stage 4. It was when I was in between that diagnosis, because I had had surgery a couple of years ago, and then re-diagnosis when I was in between that and starting treatment. And I was, a ball of anxiety of like, what am I supposed to do now? Just like go home with cancer? And he said, you know what? Here's what I'll tell you to do. Do what you want to do, and don't do what you don't want to do. And that was really good advice. And that's in the back of my mind and the front of my mind all the time, as far as not delaying the things I wanted to do, like going on my dream trip that I had planned already, and saying no to things that are a pain in the ass you just don't feel like doing, like going to your company Christmas party and small talking for 5 hours or whatever. So that meant a lot to me. I think about it all the time, and what a treasure Dr. Bird is, and everyone here. So thank you.
I think it's fitting that we end with a quotation from our friend Dr. Bird. The next time I see him, I'll tell him that he was quoted to end the symposium. So I thank you all for trying something a little different with that. Welcome your feedback on if that was good or if I shouldn't ever think about messing with success again. So a few final housekeeping points. If you haven't stopped by the tables, lots of information about the Fred Hutch melanoma initiatives, the DUO study, and MRF's work, which is all very important. So there's still handouts out there and in your folders. Please fill out the paper feedback forms or access the form by the QR code on the agenda. We literally, Ritu and I are going to meet in about a month and go through all of them in detail, so it really does inform what we do for next year. One last comment, I think in the MRF presentation, I just wanted to highlight local event, October 4th, 2026, Miles for Melanoma 5K in Marymore Park. So in your folders, there's more information about this, but I just don't think this got quite highlighted, so I wanted to make sure you were aware. Lastly, the thank yous. We had a wonderful lineup of speakers. Most people I asked to speak at this say yes, and I think it's amazing because it is a Saturday and people have a lot going on, but the speakers almost always say yes, which is lovely, and I just thank them. Wonderful set of talks. I'd like to thank Ritu, Alana, and Cody and her team. This honestly wouldn't happen without her. She's an unsung hero in her team, so big thanks. She keeps me on track as we get closer and closer to the event and helps me not forget anything too major, so I really appreciate that. And then lastly, to thank you. So this is why it happens. It's why I look forward to thinking about next year's event on my way home today, how to make it better, meaningful, how to spread the word. I'm already excited about next year's version, and I always leave this event feeling like it was very meaningful and positive. So I just want to thank you all for being here, and to those of you who shared as well.
Quick question is, there are some of the slides throughout the presentations today. I'd like to be able to look at those again, so this whole presentation will be viewable. Okay.
Great. So we will send you the links to the presentations because you registered. So we'll send it to you. It's also, if you Google Northwest Melanoma Symposium, you'll be able to find it on YouTube when it posts. So all of the talks will be available in that way. Great thing to clarify. So yeah, I thank you very much. Everyone go enjoy the rest of your Saturday, and we'll see you next year.